Good morning, everybody. This is Linda Kopecki with the Minnesota Breastfeeding Coalition. I am the interim executive director, and I'm here with my co-chair of the summit, Dr. Pam Heggie, who is a pediatrician and IBCLC and all-around amazing partner with the Minnesota Breastfeeding Coalition. And we welcome you to the second day of our Perinatal Hospital Leadership Summit. Thank you for sticking with us over these 2 days and this crazy uncertain week with the election that will never end. And so we're grateful that you're here as a wonderful distraction to the ongoing election. And just want to go through a couple things. That's us, Linda Kopecki and Pam Heggie. And I want to start, as we do with every session that we have, with an acknowledgement of where we are right now. So the Minnesota Breastfeeding Coalition takes a moment to acknowledge that we are all living and working and viewing this virtual workshop on traditional, ancestral, and present-day home of Indigenous communities. Locally, we were on the unceded land of Dakota and Ojibwe, communities that have thrived for many centuries by living close to the earth and by nourishing their infants with breast milk. The tradition of breast milk as each and every Native newborn's first food has been disrupted by colonialism, forced separation of families, and historical violence, which includes epidemics that are introduced by colonizers. The Indigenous Breastfeeding Coalition of Minnesota works diligently to reclaim breastfeeding as first food sovereignty. And they do this work alongside many Indigenous and non-Indigenous lactation professionals, advocates, and organizations, which include the Minnesota Breastfeeding Coalition. We are grateful for their leadership and the constant reminder that much more is yet to be done to address past and present wrongs. And we humbly pledge to work alongside them until all communities in Minnesota experience breast and chest feeding as the normal infant feeding method. Before I hand this off to my co-chair, I just want to remind you, all attendees and panelists and hosts, that there will be questions and answers at the end of each section. So, and we can use the Q&A section. This is what Zoom webinars. We have chat, but we also have the Q&A. So please put your questions for the panelists in the Q&A, and you can put them at any time during their presentation. And then at the end of each presentation, we will ask those questions orally. Some of them we may be able to respond to by typing in a response, but most of them we'll be doing orally. We may combine a couple questions. And also a reminder that the evaluation will be sent out on Monday, and that evaluation will link you to your continuing education credits and your certificate of attendance. We'll be sending out the recordings of both days. We'll send out the videos that will be shown, and they'll have transcriptions on them, so you can read along while you're listening to the testimonies from our providers. And we'll send out the link to the evaluation on Monday. So I'm going to pass this over to my wonderful co-chair, Dr. Pam Heggie. And here you go. Thank you.
Okay. Hello, everyone. Welcome to the second day of our now 7th Perinatal Hospital Leadership Summit. We have another exciting day planned for you. And here's the agenda. We'll be meeting like we did yesterday between 8 and noon. And we have a very short break in the middle of the morning, and we want to encourage you all to come back after the break quickly, because we'll show another video of a healthcare provider story right after the break. For those of you who were not here yesterday, and just an update about what we do for these summits, we always invite national speakers to come and share with us cutting edge information about breastfeeding and maternity center care. And we also make a point of inviting local speakers from our Minnesota community, which is a really important part of our summit, really to share best practices that they're doing in their sites and for all of us to be inspired. And we certainly were yesterday, and we look forward to hearing today from many people from all over Minnesota. And before we get started and I introduce our first speaker, we'd like to have a poll. And so Linda will introduce that. We often at other summits, we have people raise their hands about where they're from and try to get a sense of the roles that people have in their maternity centers. So Linda, why don't you explain the poll that we have?
Thank you. I just launched it and people are actually voting, which is nice. And you can choose multiple options because we know that many people have multiple roles. Just want to see exactly where you're coming from, what your perspective is, what your role is at your organization. And half the people have responded. And we're getting pretty close. Now we're at 2/3. Leave it open for just a few more seconds. And I know that panelists cannot do the poll, so these are just attendees and not panelists. Okay, I'm going to end this. This is not quite everybody, but it's a good sampling. So most people are lactation professionals or nurses. I know we have a couple doctors that are on the panel, but not in attendee mode yet. Some administrators, WIC, health department, but primarily nurses and lactation professionals. Okay. That's it. Thanks.
Okay. So we'll move on to our first speaker of the morning. So it's my great pleasure to introduce Dr. Bobby Phillip. Dr. Phillip has been an inspiration to me over many years with her advocacy for breastfeeding and baby friendly and leading change. And it's my honor to introduce her today. She's a professor of pediatrics at Boston University Medical Center. She's a fellow of the Academy of Breastfeeding Medicine and a fellow of the American Academy of Pediatrics. She works at Boston Medical Center, where until last year, she was the medical director of the mother-baby unit and co-chair of the Baby Friendly Task Force, which she's been in those roles for many, many years. In those roles, she led the hospital, the Boston Medical Center, to be one of the first baby-friendly hospitals in the United States in 1999. Since that time, she's led the hospital through 3 baby-friendly redesignations every 5 years, and most recently in 2019. Dr. Phillip will give 2 talks today. The first one is about baby-friendly, and the second one at the end of the morning is about the care of late preterm infants. So it's my great pleasure again to introduce Dr. Phillip and welcome her here, and she'll be talking today about 20 years baby-friendly reflections on change.
Bobby, I just stopped sharing, so you can now share your slides and you can share your video if you'd like.
All right, I'm working on it.
I know, this is great.
I'm getting there. Here we go. Let's hope this works.
You're quite the professional. Perfect. Okay, and I'll mute myself now. Thank you.
Share video.
If you'd like.
I tell you what, I would like to, but I'm afraid I don't want to mess things up. So can you hear me? Can you hear me?
Definitely hear you. This is perfect. Thank you. I'll mute myself.
All right. So I'll share my video this afternoon because the IT stuff kind of freaks me out. So Pam, thank you so very, very much for that kind introduction. And I just want to say thank you to the Minnesota Breastfeeding Coalition for inviting me to speak today. And I want to say a big hello to new friends in Minnesota. I'm very honored to be here today and enjoyed yesterday very, very much. And I've really enjoyed speaking with your leadership and learning about how you all are doing with your advancing breastfeeding and supporting mothers and babies. And I have to share with you, it's quite humbling to be speaking to the state that for the 2020 CDC report card ranks in the top 3 for almost every metric that was analyzed. So congratulations to you. So let's get going. I have no actual or potential conflict of interest to disclose. And the objectives of this talk will be to define what the Baby Friendly Hospital Initiative is, describe stages of change where I work at Boston Medical Center over 20 years, and I can't even believe I'm saying that, but 20 years since we got our first Baby Friendly designation. It truly seems like yesterday. And then I would like to share with you a number of the new initiatives that are taking place on our mother-baby unit, and review outcomes at our hospital, and then discuss the COVID virus in the context of Baby Friendly in the 10 steps. So Linda, I hope you can hear me and everything's going okay.
I can definitely hear you, and it's perfect. Thank you so much.
All right, great. All right, so here we go. So I am speaking to you today from Boston, Massachusetts, where it is just a beautiful, balmy 70 degrees. It's going to be a great weekend. And in Boston is the hospital where I've worked at for many decades, the Boston Medical Center. And so just to describe to you our hospital, we are a terrific hospital. We are a safety net inner city hospital. We have a 30-bed postpartum unit. And then we have a level 3, 22-bed NICU. We're affiliated with Boston University School of Medicine. We are a training site. We have residency programs in pediatrics, OBGYN, and family medicine. When I attend on the unit, I will usually have 4 residents that are working with me and 2 medical students and a nurse practitioner that's just on my team. We serve poor, minority, and immigrant families. We take anyone. It doesn't matter if they have insurance or not. They are welcome in our hospital. And we care for a lot of mothers who are struggling with substance use disorder, which we used to call NAS, and now we're calling NOWS, so Neonatal Opioid Withdrawal Syndrome. So this is a picture of Boston Medical Center on a spring day. As Dilbert said, change is good, you go first. So in 1997, this is where we started. At the time, we had 1,800 births per year. The way that we operated was that we had 1 nurse for the mother and we had 1 nurse for the baby, which I had trained there, and I just thought that was how you did it. What did I know as a pediatric resident way back when? I just thought that's how you did it. And I also thought all the babies in the nursery was just the way you did it in maternity. We had no skin-to-skin contact in labor and delivery at all. Babies were born, went right to the nursery. Amazingly, we had no lactation consultants on our unit. No one was getting any education on lactation medicine. And we had Larry, the formula guy, and all of his free stuff. And that had been the way I had seen it when I was a resident there, and now I was faculty there. And that to me was just no normal way of doing things. And in 1977, this is no joke. If you would say the word breastfeeding, this would be the response that you got. Things have changed since then, which is great. But back in 1997, you know, people would have their beepers magically go off and they would stand up and leave meetings and they would start reading the books in front of them. So you say the word breastfeeding, it was not met with any interest at all. And so in 1997, we formed our task force. Our first meeting was September of 1997. 3 of us just appointed ourselves co-chairs. That was easy. We decided we would have monthly meetings, and the big draw was we would buy pizza for everyone. And they were multidisciplinary. We tried to get as many people from different groups to join as possible. And when we met that first day, we sat around, and I was one of the co-chairs, and I was just so brilliant at the time. We were talking about, you know, what could we do on our unit that would support breastfeeding, because we really weren't doing anything. And as we were talking through it, one of the people in the group actually said, you know, maybe if we really get going on this, we can try to become a baby-friendly hospital. And this brilliant co-chair literally said, I don't even know what that is. What is that? And so the person described that it was this new initiative, and we had to follow these 10 things, and we had to pay for a formula. And I said, are we even paying for a formula? We didn't know. And naively, I said at the meeting, oh yeah, we can get that, no problem. So we started by saying, well, let's get some data on the unit. And so this was 1997. We asked the question, hey, so, you know, you guys nurses and everybody that work on the unit, what's the breastfeeding rate on the unit? And literally people looked at us like, the what? What's the breastfeeding rate on the unit? No one had ever collected it, ever. So that was the first thing we did, was we collected breastfeeding rate. And we found that on our unit, the exclusive breastfeeding rate was 5.5%. So anything we did was going to improve that, right? So we started, the task force work from 1997 to 1999. We tried to figure out where to start. We got our data. When we started to talk about change on the unit, we found that some habits were going to be extraordinarily hard to break. You know, change in a hospital setting is really, really hard. This is one of my favorite pictures. This was not our unit, but we certainly on our unit had a formula feeding culture because most of the moms were formula feeding. And almost at every step, we met resistance to change. It just seemed to me like everything was a fight. And there were really three major issues that came out as we were trying to advance the 10 steps. The first one was the issue of separation of the babies from their mothers, because remember, this had been a long-standing way that things had been done on the unit. So we had the nursery pit stop. You know, the babies were born and they go into the nursery and they, you know, one time we did a where's Waldo, where's the baby? And the babies were getting stuck in there for 9 or 10 hours. If you look at the history of how we got there, remember that in the early 1900s in the United States, hospitals were built. And due to a fear of infection, hospitals were built with nurseries because they had to figure out in these hospitals, who did they need to protect from these things they were learning about called germs and bacteria. So they figured they had to protect older people because their immune systems were down, and they had to protect new babies because they certainly didn't want anything to happen with their new babies. So so hospitals were built with these boxes, these nurseries, and systems were set up that drove the newborn baby into the nursery. And, you know, nurses who worked in the nursery, and I'm friends with them all and I respect them highly, but they definitely had ways of doing things. And they had everything set up and they wanted that baby to get in there. They wanted to do their checklist because they had great fear that it was going to be another baby and another baby. And I don't know what nursing school was teaching this way of getting length, but I just find it kind of funny. So they had ways of doing things. So that was the nursery pit stop. The second thing we had to figure out what to do was the night nursery, right? So all of these babies were going into this nursery. And this is babies in the 1950s in the nursery. This is babies in the 1960s in the nursery. And here's later on. And this is even babies in Michigan in 2010 in the nursery. So we had the nursery pit stop, we had the night nursery, and we had exams and testing in the nursery. We had, you know, the doctors that couldn't imagine, they just could not imagine doing a physical exam on a baby all alone without the parents in the nursery. And all of the tests were being done in the nursery. Hearing, you know, newborn metabolic screen test, all in the nursery. So we decided the one thing we were going to try was we were going to change this one nurse for the baby, one nurse for the mother. We were going to do this thing that I just learned about. It was called couplet care. Who knew that hospitals were doing couplet care? And in couplet care, as you guys all know, it's the same nurse for the mother and the baby. Wow. So that was just a huge fight because one of the big issues was simply how uncomfortable some of the nurses were with caring for babies. You kind of had the nurses who were really comfortable with the mothers, and then you had the nurses who were really comfortable with the baby. And the nurse that stands out to me is Maria Ra. She would be our nursery nurse, and man, she knew babies. But this was going to be difficult as we tried to get nurses to be comfortable with taking care of a mother and baby on a mother-baby unit. Imagine that. So the first issue was separation. The second issue was that maternity staff had no training in lactation medicine. The nurses, the doctors, nobody. So the big question was, so how in the world do we pay for that, right? This was going to be a new expense, and we had to figure that out. The third issue was that we were going to have to start paying for our infant formula. And this story I will never forget, because for the life of our task force, we could not figure out how to figure out if we were paying for formula or not. And I was asking everybody, like, who like has this contract? Who has it? You know, we must have brought it up for a good 6 or 7 meetings. Anybody know anything about the contract? Who has the contract? And we finally found out who had the contract and was talking with the formula company. And it was the representative on our unit from the dietary team. And she had sat in all these meetings and heard all of our plans and was the person who kind of had the contact with the formula industry. So she was quickly asked to leave the task force. So we had to figure out how to pay for all of the stuff Larry was giving us, the pizza and the lunch and the pens and the calendars and all of that. And that would mean on our unit that we were not going to give out these discharge bags we had been given to the parents, that we were getting from Larry for free. And holy mackerel, was that a fight. So we found that contract, and actually here was the contract right here. And if you look at it, you can see it says, "Dear Mr. Motley, enclosed you will find a listing of products in the Ross Hospital formula system." See that sentence there? "Effective immediately, the following products will be at no charge." And this was the second page following that. And these were all of the things that we were getting for free from Larry. And so paying for the formula became a big issue. And one of the things that happened was that as we really got down to the nitty gritty, the formula reps started sending around this rumor that it was going to cost Boston Medical Center $100,000 to pay for formula for the year. Well, we don't have a lot of money at our hospital. So when the president of the hospital and the board of trustees heard this quote of $100,000, they voted on it the first time, and it was a unanimous decision that no, we would not keep pursuing the baby-friendly hospital initiative. So we took that back to the task force, and one of our models for on the task force was we just simply were not going to accept no as the answer. So what we did was we just didn't believe $100,000, because at that time, with all the changes we had done with the 10 steps, we had a whole lot of moms breastfeeding. So we just couldn't believe that number. So we went to every single unit that was using formula, the ER, the pediatric wards, the NICU. We went everywhere, and we counted up all the formula that we were using, and we estimated an amount that would be fair market value, and we found out that it was going to be $16,000. And interestingly, as we look back over 20 years, that was pretty spot on, $16,000 or $20,000. And so we got the support of the chairman of pediatrics, the chairman of OBGYN, the chairman of family medicine, and we asked the president to take it back to the board, and it was approved that the hospital would pay for formula. So indeed, in 1999, we were designated as a baby-friendly hospital, and there is a picture of me on the left. I don't look like that right now, but I will see you later on. And we became the first hospital in Massachusetts, and we became the 22nd hospital in the nation to get baby-friendly. So that was 1999, guys. And so what I did with this talk was I really divided the talk into 2 decades. And the first 10 years, so the first decade of getting baby-friendly, really, we just really kept working on the basics, because we had changed a lot of things, but we want to make sure that it held, right? So baby-friendly never expects you to be 100% with anything, but on any given day or any given week, they would like you to be practicing the steps at a greater than 80% level. So we just kept working on the basics. So skin to skin, we had tackled, and remember the definition of skin to skin for a vaginal birth is that it's immediate and uninterrupted skin to skin contact until the completion of the first breastfeeding, or for at least an hour if the mom's not breastfeeding, and then you're going to help the mom with how to look for signs when the baby's ready to feed. And if she needs help, you're going to help her. So we shared that with we kept going to labor and delivery and answering their questions and always emphasizing that it was safety first. If there ever was an issue with the mother or the baby's health, then that took precedent over anything. And we just kept answering questions. This is a picture of my daughter, Jessica, and my first grandson, Anthony, who had their baby at our hospital 2 years ago. And she really, really, really got great care. And I shared with Linda an article that Baby Friendly USA wrote up about her experience having the baby at our hospital. And look at Jess. You can tell she just is a mass in oxytocin right there. And there's little Anthony doing nice, safe skin-to-skin holding after a vaginal birth. This is another friend who had a baby, and they're drying off the baby, making sure everyone's okay, and then skin-to-skin starts. And ideally, not ideally, it's supposed to be uninterrupted for at least an hour. And here's a picture of Wendy with her baby. So, hey, so what if the mother doesn't want to breastfeed? And we have a lot of mothers at our hospital that don't want to breastfeed, that they've been educated and they don't want to breastfeed, and that's cool. We still recommend that skin-to-skin contact in the first hour is recommended for all babies. For mothers who don't want to breastfeed at our hospital, they've received education, we've talked with them, that's their choice. We actually call them an IFF, which means informed formula feeder. And that means that we move on and we try to help them with things to feed their baby well as a formula feeder. So the 5 things they get at our hospital is, number 1, we encourage skin to skin. Number 2, we talk to them about the appropriate volumes to feed of formula each day. We encourage paced bottle feeding with a slow flow nipple. We do talk to them about using pacifiers because it's protective against SIDS. And when they leave, we give them information about how to safely prepare formula. So those are the 5 things that formula feeding babies get at our baby-friendly hospital. What's the rules for C-section? The rules for skin-to-skin is that it starts when the mother is alert and responsive, and then it's uninterrupted for an hour. So these are pictures. These were not taken at our hospital. These are pictures of the mother doing skin-to-skin in the OR. These are pictures of gentle C-section, which is where they use the clear drape, and then the mother holds her baby. I will say that this is a tough one at a baby-friendly hospital. We know the rules. Sometimes we can do skin-to-skin in the OR, but it really depends on staffing in the unit, right? Because when that baby's born, you have new patients. So you have to get an additional nurse in there. So we really try to do skin-to-skin in the OR. But if that doesn't happen, we guarantee that it happens with the mother once she gets to the PACU, and then the baby is held for an hour and it's uninterrupted. And Baby Friendly says that's okay to do. I would love that to be in the OR for every single mom, but in reality, sometimes that's hard. Sometimes our unit is pretty busy because the babies can sometimes come in a big bolus. We do a lot of skin-to-skin holding on our unit. So let's say these are pictures when the mother became sick. We seem to have a lot of moms that have a lot of bleeding problems. We have high morbidity on our unit because our moms have high blood pressure. A lot are obese and have a lot of stuff going on. So if the baby is brought to the nursery because the mom's just not available and there's concern about her safety, we always encourage the other person that's with the baby to come to the nursery and to hold the baby skin to skin if they would like. And I must say, for the dads, we've really never had a dad refuse. They're happy to do it. And I'm always the one to take their camera and take a picture of them so that she'll have to show mom. And I just want to show you in these pictures that we really encourage the families to hold the baby in a safe fashion so they're a little bit upright and that they can see the nose and the mouth. And we don't want that little neck getting kinked down. The woman on the right was a doula. We have a doula program at our hospital. She's holding that baby. She was the support person for the mom see the white band she has on her arm? So the mother had given approval for her to come hold the baby. Skin to skin's pretty magical. I hope you're all doing it. We really, really recommend it no matter how old the baby is. I always say to parents, this is like a trick you have in your back pocket all the time. And we always talk to them about safe skin to skin holding. And dads really, really love it. All right, so we were working on the basics these first 10 years. Remember, everyone, that rooming in means, rooming in is 24 hours a day is the standard care for the baby. And you're allowed up to an hour a day for the baby to be out for something like a circumcision when the baby needs to be out. We do our car seat tests in the nursery, so the baby has to be out for that. We do our tongue tie clips in the nursery. And so when the babies leave the mother's room, we just document in our chart the time that the baby left, the time that the baby returns, and what the baby was out for. Healthy births, no more nursery pit stops. Here's my daughter Jess, her husband Philip, my grandson Anthony, and they were preparing to go directly to their room, which was room 401. And the physicians now do the exams in the room. This is my friend Paula Schreck in Michigan who allowed me to use this picture. I honestly can't imagine examining a healthy baby without a parent there. It just makes so much sense. It's so much faster to answer their questions right there. This is a picture of the level 1 nursery at our hospital. We do have a level 1 nursery. We are required by Mass Department of Public Health to have a level 1 space because we can take and watch babies who are like breathing a little fast, or we can watch them there if their mom is getting sick or something. So that's our nursery, but this is what it often looks like. It is staffed by a nurse, but when it's not busy, the nurse just goes out to the unit to help out with things that are needed out on the unit. So yep, we gotta have a nursery. We kept working on the basics, and I gotta say, of all of the steps, by far, step 3 for us was the hardest. And when I try to help hospitals with baby friendly, I think step 3 is the hardest one. That's prenatal education. The baby friendly would like the education to begin in the first trimester. And then when they come for a site visit, mothers in the 3rd trimester are surveyed. They expect that written information is given out in the beginning and, quote, reviewed. And they want the mothers to receive education on the importance of breastfeeding, the importance of exclusivity for 6 months, basic management of position and latch, what skin to skin means and kind of the rules that we're following, what rooming in is, and then the risks of supplementing while breastfeeding. I bet you we have tried 5 or 6 different ways to make this happen. Every year, we just kept working on this. We'd put something in place, we'd go and audit it, it wouldn't stick, it wouldn't hold. So I'm gonna share with you down the road something that we did before our last redesignation that really worked. All right, so that was the first 10 years. Now I want to move on to the next 10 years, which was 2009 to 2019 and things that have happened. So we moved right along. We had really gotten the basic 10 steps in place. And now it seemed like the chaos on our unit had decreased. Things were kind of calm. People kind of were following policies. We had nurses that were comfortable with things. The amount of fighting had decreased on the unit. And so we started to move along and we said, what should we do about tongue ties? And we decided as a unit that because our families have such financial challenges in their lives, that it really wasn't a safe or a good idea to say, oh yeah, here, your baby has a tongue tie. Here's an appointment to see the ENT group in 5 days. And they'd have to get on. We found most of our moms take 2 or 3 buses to get to our house, to our hospital. So we said that wasn't gonna be okay. So we decided that we were gonna clip tongue ties before the baby leaves. And indeed, our ENT department was terrific. And here is a picture using a Mickey Mouse tool. You can see the tongue tie in the middle of it. And they will come down and clip tongue ties for us. Certainly over the years, we've learned that tongue ties, it's not about appearance, it's about function. So we look for tongue ties on every single baby, and we show the parents, and then we monitor how the feeding's going. And if there's excessive weight loss or excessive pain, or the latch is just not holding, then we will get the tongue tie clipped. I'm sure someone's going to ask about lip ties. We note lip ties, but we're not clipping those in our unit. We just don't feel that the literature is quite strong enough for that. So we just clip tongue ties, and they don't use a laser, they just do a clip. Some of the pediatricians have been trained to do it, which is nice. The family med docs do them. Some of the pediatricians do them. And right now we have a bunch of doctors that are interested in doing this. So a lot of people are interested in doing this now. It does make a big difference for some babies on their latch. I'm going to take you through the years. So we're looking here at 2009. So year by year, these were the things we did. The first thing we did, we got the tongue tie clipping in place. Then we talked about delaying the bath. So this was really interesting in our unit because I remember it vividly. I had heard about this hospital in the northern part of Massachusetts called Melrose Wakefield Hospital. And the rumor was that they were delaying the bath. You know, our bath was being done, once skin to skin was complete, the bath was being done after that. So we now delay the bath to 12 to 24 hours of life. And the bath is done in the mother's room because we practice rooming in. And I will share with you that we haven't studied this, but it's definitely something that we have seen. Two things have caused our hypoglycemia rate to almost disappear. One is being very aggressive about doing skin to skin in labor and delivery. And the second one was delaying this bath. And by doing that, we used to have 2 babies on IV drips back when. And by doing the skin to skin and by doing the baths in the mother's room, we just don't see it very much anymore. I mean, we will have some if the mom's a diabetic on insulin and the baby's SGA. Some babies will get into trouble, but really not many anymore. And these are pictures that were taken in our new unit. And you can see that little tub, that sink that was specially ordered to allow for baths in the mother's room. Baby Friendly does not say you have to have any amount of lactation consultant staffing. They don't say that. But we looked at A1 standards, and we also looked at a paper that I think Miriam Labak had published. And we felt that we just really didn't have enough lactation consultants because by now we were having a lot of breastfeeding. So the nursing group was great. They increased the amount of staffing. So this is what we have now. We have 3.4 FTEs. Now we have 2,800 births, and they also cover the NICU. And if possible, they go up to the pediatric wards and to the ER if possible. In 2011, we got donor milk in our level 3 NICU. This is a picture of the first bottle of donor milk that was used in the NICU. In 2012, we had, because we were the first baby friendly hospital, we were not giving out those discharge bags that Larry had given us. And then we started to talk with other hospitals, and in our collaborative, we were saying, why are we giving out these bags? The literature is showing, even if you take the formula out, it causes the mothers not to breastfeed for as long. So we worked very hard on this. And in 2012, Massachusetts became bag free. All 49 hospitals in our state banned the bags. This is a picture. I live in Lexington, Massachusetts. So this is down at the Commons, about a mile down the road from my house, of the Minuteman waiting for the Brits to come marching in to start the revolution. And the tag here is "Pass the word, Massachusetts is bag free." I would love to hear how you all are doing in Minnesota on banning the bags. We had a party and we went down to the harbor in Boston where the Tea Party was held. And you might have seen this picture. That's us pretending to throw the bags like the Tea Party did. We didn't really throw the bags, but we had a photo op. In 2013, I'm giving you things that are happening over the second decade of Baby Friendly. A significant thing happened, and that is Ginny Combs was hired as the nurse manager of our mother baby unit. Ginny is a passionate advocate for the very best mother-baby care, no matter what. It's all about family-centered care on our unit. And she came in and made quite a few changes on our task force. She had a lot of ideas. So the first thing she said was she really wanted to get quiet time on our unit, because we were seeing mothers who were quite exhausted and having on that second day their kind of emotional breakdown when they just would be crying and they had just had it. So she was instrumental in helping us to get quiet time from 2 to 4, 7 days a week. This took a lot of work. There's a lot of people on the unit, right? The birth certificate team had to change their hours. She had to talk to the dietary team to change the hours they were picking up trays and dropping off trays and getting food orders. We had to talk to the security folks who were doing checks. We had to talk with housekeeping and have meetings with them. And a lot of people had to change their schedules. And but we were successful, and we got quiet time in 2014. Now, again, a lot of the stuff I'm talking about, baby friendly, does not say that you need to do it. But I think once you find that you get the chaos controlled on your unit, it's kind of fun to be doing more things, and you start to see more benefit from those things as well. There's Ginny. So Ginny is the person who is in the upper right-hand picture. She's the one with the blue gloves on and the glasses. And she was absolutely instrumental in getting donor milk on our level 1 mother-baby unit. Now remember, the NICU already had it, but we wanted to get it on our level 1 unit. And she really made this happen in terms of writing protocols, buying this machine that you use to warm up the donor milk. I didn't know there was such a milk warmer machine. Making sure we had the freezer, making sure we had all the temperature things and the logs, and everyone had to get trained, and it was a big deal. And initially there was a bit of a yuck factor on the units from both nurses and families. But remember, this was now 5 years ago, and using donor milk on our unit has definitely become much more accepted. I'm going to talk about who's getting consent on these. When we started, the consent, we had to go through the legal team and the ID team at the hospital, and the legal team at our hospital said that we had to get consent to use the donor milk, and that it could only be obtained by the doctors or the nurse practitioners or the midwives. The lactation consultants and the nurses weren't allowed to get this consent. This has changed this year. They can get it now, but when we started, it had to be a doctor, an NP, or a midwife. And there's a picture of our little freezer that we use, and there's a picture of some of the donor milk. We're very lucky. We have a milk bank right about 20 miles from Boston. It's the Mother's Milk Bank Northeast in Newton Upper Falls. And so that's where we get our milk from. Ginny was instrumental in opening up 2 baby cafes, one in 2013 at a neighborhood health center near our hospital called Codman Square. That one is under our auspice. It's paid for out of BMC. Oh, I want to go back. So who's paying for this donor milk? I'm sorry, I wanted to tell you that. The donor milk is being paid for out of the nursing budget. So we're paying for that for families. And then in 2016, we opened up a baby cafe at Boston Medical Center. So for those of you who aren't familiar with what a baby cafe is, it was a program that started in the United Kingdom, and Lucia Jenkins brought it back and became the director of Baby Cafe USA. A baby cafe is a support site where women can go with their babies. It's always run at the same time. You don't need an appointment. You can just go. And when you go, there are 2 people there who have training in lactation. It serves as both a breastfeeding support place and also just a mother-to-mother support place. When my daughter had Anthony, she and I every Friday for 3 months at 10 o'clock would drive to Melrose Wakefield and go to the baby cafe. And it really helped her. I saw firsthand how much the mother-to-mother peer support was to help her, because my daughter had some trouble with breastfeeding, of course. And after the 2nd month, I said, gee, Jess, you're doing great with breastfeeding. I'm not sure we need to go to the baby cafe. And she said, no, I really want to go, because all all those moms helped me so much. I want to be able to help other people. So we would go, and it's great. You know, it has a scale. The moms can weigh the babies. There's some food there for them. And now with COVID, Baby Cafe is still happening. It's just virtual meetings. Baby Cafe is terrific. In 2016, we got a new fleet of Symphony pumps. Who knew? The pumps we had looked fine to me, but Ginny said, oh my gosh, they're quite old, the ones that we had. So we got a new fleet of all these new pumps. And what we did a lot with all of these new initiatives is that we would always take a moment to celebrate and cut a cake. So here on the left is Ginny, and here on the right is Marcy, who's our lead lactation consultant, and you can see the cake says happy breast pumping. We just took a moment to celebrate that we've gotten all of these new pumps. Again, baby friendly does not say we had to do that, but we had a lot of moms that were breastfeeding, and we were really trying to support them. So it was just something that we wanted to do. So cut a cake was always an important thing. Cut a cake and take a picture of cutting a cake. All right, September, we're now at 2016 of this second decade. We were still doing phototherapy in the nursery. I think all hospitals find that certain things are just really hard to break. And this was one for us, phototherapy in the nursery. Ginny came on board and simply said to her staff, to the nurses, she didn't understand why it was so hard. And she just said, we are going to try with one baby, one nurse, one doctor, one family to do phototherapy in the mother's room. And we did, and that's what we do now. It's no big deal. Babies get phototherapy in the mother's room. Not sure why it was so hard, but it was. 2016, Ginny started a program called We Pump. So this is a baby-friendly requirement. If the mother and baby are separated, the expectation as a baby-friendly hospital and to offer the best evidence-based care is that the mom will be, if she's stable, will be supported to pump or hand express by 6 hours after birth at the latest. And the sooner, the better. And so Ginny rolled out this initiative called We Pump, which is very clever. And she started collecting data. And as Ginny does often, and we tried to model, we would just find champions that were doing things and congratulate them. So you can see Jess Young, she got a star. She had a mom who started pumping 1.5 hours after birth in labor and delivery. Larissa got her mom pumping at 4 hours, Lorraine at 4.5 hours, Flo at 5.5 hours. So by recognizing good work on the unit, you can make it progress. 2017, we started using neonatal glucose gel for the babies that were having trouble with their blood sugars. As I mentioned before, we had a lot of babies getting glucose and stuff and having to go to the NICU. And now babies who are in our unit and have sugars that are a little bit low can receive up to 2 gels in the mother-baby unit. They're given in the nursery because the baby's being watched in the nursery. And for the question, we use the number of 40, that we like term babies to have a blood sugar of greater than 40 in the first 24 hours. We do try to use colostrum or donor milk first. I will share with you, it was one of our challenges because the donor milk, we had to get consent, which took a while, and the mother, might have been sick. And then if we did have consent, it had to be thawed, and that just took too long. So that was a challenge that we had. Now that Habana has said that you can use thawed milk for 48 hours, now we seem to have more milk that is thawed. But we do try to use colostrum or donor milk first. But now with gel, we have a little more wiggle room on that. So it's great. I shared with you, we take care of a lot of moms who are struggling with substance use disorder, and the babies go on our NOWS protocol, neonatal opioid withdrawal syndrome. Everything I'm going to share with you that we're doing is under the direction of a neonatologist at our hospital, Alicia Walkman, who now has a national reputation for the amazing work that is happening for these families. We practice on our unit non-pharm care, so non-pharmacologic care. And this is the medicine we give to these babies. We encourage rooming in. And because we had been doing rooming in for baby friendly, this was not a big step. We had already been doing it. We encourage that it's a quiet environment in the mother's room. So it's inside voices, the shades are down, the lights are dimmed. It's a quiet environment. We absolutely encourage parental presence, if safe, obviously. Safe skin-to-skin holding, always being able to see the eyes and the nose. Swaddling. We encourage optimal feeding. We encourage breastfeeding if the mother meets 4 criteria. Number 1, she's in a treatment program. Number 2, she is compliant with that program. She's not jumping around from program to program. Number 3, that she's had 5 or more prenatal visits. And then the 4th one is that she is on her UTOX when she arrives. She's appropriate for what she's being prescribed. Those are our 4 criteria. And if they meet that and they want to breastfeed, we support it. And we limited visitors before, but now with COVID, visitors are being limited. So the now's breastfeeding is very strongly supported because we know that they end up not having to stay so long. Again, to share with you, you might want to write these down. This is what we're doing, and I know Alicia has published this. We, in a program, compliant with a program, 5 or more visits, and UTOX consistent with meds. We follow the, we used to use the Finnegan score. Alicia taught us that that was never a validated score. I just couldn't believe the meeting because I had used Finnegan for like 25 years. But now we use eat, sleep, and console. These are what a baby's supposed to be able to do. How are they doing eating? How are they doing sleeping? And how are they doing consoling? And if they're getting into trouble with any of those, the first thing we do, we have a huddle on the unit where we get the nurse, the parents, and the docs, and we go in and talk to the family and see what their opinion is. And then if the baby needs a little help, we now can use PRN methadone. We can just give 1 dose and watch. Maybe the baby will need another dose and watch. And that's how we do it. We no longer have to give the methadone in the nursery. It can be given, and the baby can go back to the mom's room. So our NOWS program is amazing. You can read about her stuff in Pediatrics in the New England Journal. Reflections on that. There aren't fights on our unit. We were doing it wrong before. We were separating the babies. We were taking them to the nursery to do the Finnegan score. Even the process of separating the baby was making the baby flare. The Finnegan wasn't a validated tool. We were doing it wrong before. So this is much, much better. Again, safety is always first, always, always first. We're mandated in our state that the state is notified about these babies, and then we follow what the state wants to do in terms of where they can go. But the vast, vast majority go home with the families, and it's really great. What are we doing? So second decade again, what were we doing for training? So this can be quite expensive for a hospital to meet this step 2 requirement for baby-friendly training. The baby-friendly says that the nurses need to get 20 hours. I don't know why it says 4 hours. I think that's a mistake. They have to get 20 hours. They have to do 15 hours of online stuff, and then they have to do 5 hours of shadowing. And in the beginning, we had a homegrown course for the nurses that I taught with some of the lactation consultants. But that becomes hard to do. So now the hospital is invested, and there's a lot of online courses you can use for the didactic stuff. We've chosen LER. I don't have any affiliate with them or anything. I have taken LER just to see what it was like. I would say it's quite good. It's just kind of long, but we have chosen LER. And then they do 5 hours with the lactation consultants. Again, with the providers, the rule is 3 hours of training on certain breastfeeding topics. We started with homegrown courses, and I gave grand rounds to everybody. I did a lot of grand rounds. But, there's the nurses, LER. Now, thanks to the Kellogg Foundation, they funded me to do an online course for providers. It's called Bella Breastfeeding, and it's on Open Pediatrics. If the doc or nurse practitioner or midwife takes this course and answers the post-quiz questions correctly at 80% or better, they can print out a certificate, and it fulfills baby-friendly requirement for providers. And it's free. So if the providers want to get CME credit, they can pay $30 and get CME credit, or they can take it for free. So I shared with Linda information about how to find this course and be able to take it. We just did an audit because we had to do a self-audit for a Step 2 training, and we have about 120 attending doctors, and we have just a slew of residents, and we're at about 98% compliance. OB makes any new doc take Bella before they can get on the floor, and our policy says they have 6 months to complete it, but we're at like 98% compliance, and Bella has really been a big help. For our redesignation, we told everybody recently they just had to take it because our documentation wasn't that great to have all the certificates, and they took it, and really no one complained. They said it was a pretty good course. So I do have a conflict. It is my course. I don't get any money for it at all. The Kellogg Foundation funded it. So if you're struggling with staff training, that's one idea for you all. And Linda has information on that. In 2018, I'm marching through this decade. We started our early bloomer program, and stay tuned for that. I'm going to talk about that later this morning. That's a really exciting program. I love the early bloomer program. And remember, we got designated in 1999, and we've been redesignated 3 times. Each time gives me a little bit more gray hair, I think. So 2007 was our first one. 2014 was our second one. And most recently was last year in 2019. It was time for us to get redesignated again. So to be very honest, you get baby friendly, and part of the journey is making sure that you're staying compliant and keeping up with everything that you're supposed to do. So when it comes time for redesignation, which is every 5 years, we had 2 baby friendly assessors that came into the hospital. They were going to be checking everything, looking in all the closets, checking all the logbooks. And so we had some work to do, which I'm going to share with you. But every time redesignation comes up, it's a discussion. Like the hospital says, do we want to keep doing this? Is this working? Do we want to keep doing it? So before our redesignation, we met with hospital leadership. They were asking the questions, does baby friendly work? So this is the information that our task force shared with them. This is an old study. We did this back after we had gotten baby friendly. And so we looked at breastfeeding rates before we got baby friendly. So you can see 1995 down at the left. And on the y-axis is the percent of breastfeeding. So the dark blue column in 1995 is mothers who gave at least a sip of breast milk before they left the hospital in 1995, before we became baby friendly. So we had a sipper rate of 58%, and you can see our exclusive rate there of 5.5%. And then take it over to the right, 1999, with baby-friendly policies in place, you can see our initiation rate in 1999 had gone up to 86%, and our exclusivity rate had increased more than 6-fold. It had gone up to 33.5%. Now, if you looked at our data, our initiation rate is about 90%, and our exclusive rate runs about 50-ish%. Remember, we care for mothers who in national data would not breastfeed. So we run like 50 to 60%, I would say, recently. All right, so that was a paper that was published in Pediatrics. Recently, The Lancet published the Lancet Breastfeeding Series Group in 2016. They published a meta-analysis of studies looking at the implementation of baby friendly, and they found that any breastfeeding in the hospital before discharge, so 1 sip of breast milk would count, increased in a baby friendly hospital before and after by 66%, and exclusivity increased by 49%. This was another paper that was published looking at breastfeeding, success of baby friendly. This was by Lori Feldman and the Best Fed Beginners group. This was in Pediatrics. And you guys have the slides for these. They found in the cohort of hospitals that they helped to get baby friendly, and I think you guys had a couple of them in Minnesota. They found that any amount of breastfeeding, again, that sipper rate increased from 79% to 83%, and exclusive increased significantly from 39% to 61%. Look at that. ARC did a systemic review, and their conclusion was that the baby-friendly hospital initiative is associated with improved rates of breastfeeding initiation and duration. And then most recently, Ann Meerwood, who's a colleague at Boston Medical Center, she's doing the CHAMPS program where she's helping hospitals. It's down in the southeastern part of the United States, a lot in Mississippi. And she looked at baby-friendly and if it worked. And she found that it was associated with the increases. They enrolled 33 hospitals down there, and their result was that it was associated with increases in breastfeeding rates and improved evidence-based care. And the changes were especially positive for African American women. So it decreases the disparity gap, the racial disparity gap. That is very significant finding. Their initiate SIPR rate at their hospitals increased from 66 to 75%, and among African American families from 43 to 63%. And the gap between white and Black breastfeeding rates decreased in their study by 9.6%. All right. We were up for redesignation. The hospital decided, this was what our hospital decided. I love Boston Medical Center. They decided, yep, it works. You've proved to us it works. They decided, this is what we do. This is who we are. We boast that we promote exceptional care without exception. This is exceptional care. We decided baby-friendly kept us honest. Definitely keeps the formula companies at bay. I always feel like there's a moat around our hospital and the formula industry is like crawling out there beyond the moat, and baby-friendly is what's keeping them away. It made sure that we kept our staff trained. It ensured that we do the same care for everybody, no matter who they are. But we realized before the redesignation, we had some work to do. So the first thing that we had to do was I had to figure out, once again, make sure we were paying for formula and formula products at a fair market price. And this was always so hard to figure out, but fortunately, Baby Friendly came out with this new thing called the minimum threshold price. And Baby Friendly finally said, if you are paying this amount for this product, you meet fair market value. And that was just a huge help. So you could see that one of those little bottles that you use on your unit, that let's say is a 2-ounce bottle of ready-to-use formula, if you're paying at least 9 cents for that, you are compliant. If you are paying at least 5 cents for nipples, you are compliant. If you are paying at least 51 cents for pacifiers, you are compliant. So one member of our task force, Lisa Zanni, took this on. She met with purchasing, she met with dietary, remember those guys? Purchasing, dietary, she had huge meetings. There was a vice president there. We got really lucky because there's this great guy called Vahid, and he joined that group. And in the group, I was at the first meeting with Lisa, and he said to us, we looked so nervous, we got to make sure we're paying at least this. And Vahid said, don't worry about it. I just came here. I worked at a baby-friendly hospital in Colorado. I know what we're supposed to do. So that was great. But for anyone who's struggling with paying fair market value, we really like the minimum threshold price a lot. Okay, so for step 3, just have to close the window. For step 3, again, we were struggling again because we did audits in prenatal, and again, we just weren't meeting it at 80%. So we decided that we were going to publish a video, and we got our marketing department to help us with this. And I wrote it and I edited. I had a lot of images that we used. We have a prenatal education video in 4 languages. We have it in English, Spanish, Portuguese, and French Creole. Each one is 5 minutes long. We don't want it to be really long. We want to keep people's attention. And this is how the system works at our hospital. In the prenatal clinic, when the mother checks in at 28 weeks, the medical assistant goes and gets her, does what she needs to do, and checks her into the exam room. Maybe you guys work differently than me, but they're sitting in that room for quite a while waiting for the midwives or the OBs. So she asked the woman, the mother, if she would like to watch a video that the doctor would like her to see. And she takes the mother's phone And we have a QRC code for each language. Let's say the mother speaks Spanish. She takes her phone, and all the moms have phones, and scans the QRC code. That pulls up the video, and then the mother watches the video while she's waiting for the doctor to come in the room. The medical assistant leaves and checks the box in Epic that says that she watched it. And when the provider comes in, the provider says, hey, did you watch the video? Do you have any questions about breastfeeding? Do you feel you know what skin to skin is and how long it will last? And all of the things that we want done. And so here's an example of an image. It's very image oriented. So this is an example of a teaching point. So you can see that it's, this is for feeding on cues. Don't watch the clock, watch your baby. Feed on cue, feed 8 or more times in 24 hours. Why? You get a good milk supply and your baby's happier and cries less. So I see moms who've had their babies and they talk about this baby and the clock. I do want to share with you, if you would like to see some of these videos, you could today go to YouTube and type in, search for Bella Prenatal Education video. And we have 3 languages up there. We have English, we have Spanish, and we have Portuguese. I did this project working for some of the residents at our hospital. And we just want this education to be out there for free because we struggled with it so much at our hospital. So you guys could use it. You could pull these YouTube videos up and have the moms watch it. So that's out there. So those were the things that we did prenatally. We did fair market value. We worked on our epics, so our documentation would be better, and we fixed this video thing. And then finally, our redesignation time came. And we had finally fixed that step 3. I want to tell you a little bit about Epic. We use Epic at our hospital. We have a baby-friendly tab in Epic for the maternity unit. And I personally kind of love this because I just think it's clever and it cracks me up because I thought of it about 2 o'clock in the morning. There's a baby-friendly tab they can go. And the first thing is we call it rooming in interrupted. So there's a drop down. If the baby's ever in the nursery or ever leaves the unit, there's a drop down. It's simple. It says, where did the baby go to? What was the reason? And for how long were they gone? Check, check, check. They can check in there on skin to skin if they're practicing in it. If the mom requests a pacifier and teaching's done, they can check that. If the mother requests formula, teaching's done, they can check that. And and we just added another thing to this Epic page, which is hand expression. We also this happened before designation, but we're using the early onset sepsis risk calculator, which allows us to have to give babies much, much less antibiotics, which is great. We're also doing swaddle baths. So May, baby-friendly assessors rolled in, did our redesignation. It was hard, but I think when we came out of it, we felt like, wow, the work that we did really helped the unit. We were redesignated in September of 2019, marking 20 years as a baby-friendly hospital. Yes, we did cut a cake. We actually had pizza and cake for that one. So reflections for me, 20 years of this, it's really the journey. I don't think it's really getting the award. It's the journey that's so important, and applying how you learn and how you can change for the better. Now on level 1 mother baby unit, we used to have restrictions on who could use donor milk because we didn't want to spend too much money. Now any mother that is working at breastfeeding can use donor milk, get donor milk. And I told you that nurses and LCs can get the consent. So that's a big, big improvement. To be very, very honest, over the years, things slip. One year at Halloween, we had a big project, pacifiers at the circs. Pacifiers had creeped into that circ room. I don't know how. But they had to go to the graveyard. That was kind of fun. So we used a gloved finger instead. We have to keep working on wait for the wait. And we have done hand expression refreshers for all staff often. Challenges for me personally as the director of the baby team. In 13 years, I have worked with 9 nurse managers. It seemed to be a revolving door for a while, but once Ginny came, that's really been great. Those discharge bags in 20 years returned 3 times. So we got to ban them 3 times. The last time those bags turned up on the unit, I was so mad. I left the hospital. I had another doctor take over the care. I was so upset that they had somehow returned again. So you just have to always be vigilant. Skin to Skin started to slip a little bit. And so we had a visiting professor, Raylene Phillips from California, come in for a week and do grand rounds for everyone. Fair market value, constant challenge, new buying groups, new managers, but we got Vahid down there. As long as Vahid's there, we're good now. And most recently, you know, COVID has been a challenge. So just like everyone, you know, it was a challenge for us initially to keep staff safe, to keep families safe. Following the AEP, we were separating mothers and babies were having to go to the NICU if they were a patient under investigation or positive. And that was really hard. But we kept following guidelines, and the hospital decided that one of the units that was going to get use of a rapid swab for all patients coming in was going to be maternity, because in the maternity unit, we were having a lot of staff that were testing positive. So now laboring women get a swab when they come in, and they stay in labor and delivery until it's figured out what the swab is. And if the mother is positive, the baby now stays with the mother as long, if she's vaginal birth. If it's a C-section, she has to have a support person. And we also are practicing not a lot of visitors, which has actually been awesome. We do have one family member or support person allowed to be in the room. And now I would say we had a really bad flurry of COVID in Massachusetts in the beginning. We had a big meeting in Boston that spread a lot, and we had our nursing homes that were really taking a hit. We seem to have calmed it down a little bit here. It's starting to ramp up a little bit, but COVID was a challenge for Baby Friendly. But I always say a million times, with Baby Friendly, it's safety first. So we had to figure out how to keep the unit, how to keep the baby safe. And then over time, without screaming and yelling about things, it's come to where we now do rapid tests and mothers and babies stay together. So what's happened at Boston Medical Center? I'm almost done. When we got it in 1999, everybody in Boston said nobody's going to want to go to your hospital because they're not going to be able to get formula, which was just not true. Our volume has gone up. We were at 1,800 in 1999, and we're at 2,800 now. Our breastfeeding rates have gone up. 1995 was before Baby Friendly. Our exclusive rate then was 5.5%. Now I told you it's about 50 or 60-ish in there. And our any amount sipper has gone up 58 to 90%. COVID, we've talked about. This was a QI person who said that every system is perfectly designed for the results it gets. It's no big surprise to me why we had an exclusive rate in 1997 of 5.5%. We were doing everything wrong. And certainly all change is hard at first, messy in the middle, and so glorious at the end. And I feel like we're in the glorious phase, and it's just wonderful at work. Our easiest mom is the mom who comes in and says she wants to breastfeed. We're all over that. And then we're just really trying to support mothers where they are at. So Linda, that is the end of the talk. Here in Boston, it's 10:15. So,
Okay, well, thank you. This has been wonderful. This is Linda again. I have a couple questions for you that are in the Q&A.
Okay.
Well, so one is a quick one. Actually, two are quick, and then one's a little bit longer. So I'll go with the quick ones first. First of all, the QRC codes for the videos, will you send those to me so that I can share them with the attendees?
So for the videos that are on YouTube, that's not something that I have.
Okay, so I'll just look for those videos on YouTube.
Yeah, you just have to go to YouTube and type in Bella prenatal education video.
Great, and I'll send out
codes for those.
And I'll send that out on Monday with everything, including the article that you referenced and the
Bella information.
The Bella.
Yeah, so just to explain, Boston Medical Center has QRC codes for the ones that are within our hospital system. And then we did this YouTube thing to help people out.
Okay. So the quick question is, can you describe a swaddle bath?
Yes. Jenny has taught me so much. A swaddle bath, it's done in, we buy turtle tubs. That's what they're called, turtle tubs. And it's basically using a linen piece of cloth and the baby is gently put into this tub with the linen piece of cloth in warm, tepid water. And then the nurse takes one limb out at a time to clean, puts the extremity back, takes the left arm out, cleans it, puts it back, takes the right leg out. It's a non-stressful way to give a bath to a baby. It's very, very calming. Parents love it. You could look up turtle tub swaddle baths.
Okay, thank you. Now there are two questions. The longer question is this one. So could you comment on how your hospital approaches supplementation in the newborn period? So our hospital, this is the person requesting it, she's a nurse midwife in IBCLC. Our hospital has donor milk available. I feel there is a lot of supplementation happening because the nurses and inpatient IBCLCs feel it's okay if it's breast milk. As an outpatient IBCLC, I am concerned this can undermine breastfeeding even if they have the parent start pumping. How do you decide when a baby needs supplementation?
That's a really interesting question, the question about supplementation. So, you know, it's going to be kind of a lengthy, windy answer. Baby Friendly in the last 1 year kind of tweaked the 10 steps a little bit. They eased up on rooming in. They said if the mother requests it and you document it, it's going to be okay, just as long as not all the babies are in the nursery at night, which doesn't happen. But if a mother's really having a meltdown and needs a rest, you can come up with a feeding plan. They can go in, you document that's the reason. That's fine. And they also eased up on supplementation a bit. So Baby Friendly says, again, if the mother is requesting supplementation and you've talked with her about the issues about it, she requests it, you can give it as long as you document it and try to give it with an alternative feeding method. So you saw our rates. I mean, if we have a 50% exclusive rate at our hospital and we have 90% of women giving any amount of breast milk, therefore we have a 40% supplementation rate at our hospital. But remember who we care for, women that traditionally wouldn't breastfeed. So we talk about it. We are very careful when the supplementation is to be given that we limit the volumes. We use a rule on our unit of up to 10 cc's of feed in the first 24 hours, up to 20 cc's of feed next, and up to 30 cc's of feed for the third day. I think that hopefully helps them when they leave. We try to do it with, I think the favorite thing on our unit probably is a cup or finger feeds. One of our lactation consultants really loves an SNS. She'll do that. If the family insists on a bottle, we have slow flow nipples. I don't know. I think it's hard. I think it's really hard being a nurse on these units, especially 2 o'clock in the morning when the mother's working on it and things just aren't working. So we try to go where the parents want. That's where we're at. I don't know. I just think breastfeeding can be really hard. One thing I've learned with my daughter is to soften my words because it can be really, really hard. I'm not sure I answered the question.
I think you did. Yeah. Thank you.
Hard.
Okay. A couple more questions, and then we're going to move along. There's a little bit of discussion in the chat section, and I'd love to have you comment on it. It's about the location, the setting for circumcision, the elective circumcision, clinic setting, hospital setting. There's a little bit of conversation in the chat section, who's doing what, and I'd love to have you comment on that.
Circumcisions, here's the deal at Boston Medical Center. We do them on the unit. We do not do them before 12 hours. We do not do them unless the baby's keeping their weight, keeping their temp stable, and they're feeding okay. You're going to hear in the late preterm infants, those circs are delayed. Our surgeons at our hospital, if the parents don't do it in the hospital and they don't go out and do a religious, ceremony and do it, they do it at a year, a circumcision at a year under general anesthesia. So that's kind of crazy. So I think that's a hard one too. Trying to help families out, not sabotage the feeding. I'd love to hear from you guys. But
yeah, if you look in the chat section, you'll see a little bit of conversation about who's doing what and where.
Okay.
So the last two questions are really about baths. So what's your suggestion for delaying the first bath 12 or 24 hours? And then the second question is about baths too, the tubs in the mother's rooms for baby baths. Is this the turtle tub?
We battled over when to lay the back. We just said greater than 12 to 24 and the baby has to be feeding. We give the nurses some wiggle room. No, we don't do the turtle tub. Yes, it goes in the mother's room. Yep.
Okay, very good.
I figured out how to do the video.
Yes, yes. And so when you come back later this morning, we'll have your video side by side. It'll be wonderful. I think we're going to move along. Thank you so much, Dr. Phillips. It was so nice to meet you the other day, and so nice to hear your talk.
I just now figured out how to look at the chat, so I'm going to be looking at this chat too. So thank you, everybody. I so wish we could be together. I hope you're all well and taking care of yourselves, and I look forward to the morning. Thank you.
Excellent. So we're going to be moving along to the next section, which is really about what's happening locally in Minnesota. Minnesota Breastfeeding Coalition is collaborating with the Minnesota Department of Health on a 10-step learning collaborative grant. It's through the Centers for Disease Control. It's their SPAN grant. It's for 5 years. And Carol Bussman, who's a nurse IBCLC, she's led a hospital through the baby-friendly process. She's the director of the 10-step learning collaborative. And I'm going to pass it over to her to just let us know what's happening in Minnesota with the collaborative participants. Okay, the view is good, and Carol, we don't have your audio yet. So you'll need to unmute yourself to present.
There, how's that?
Very good, sure, that's perfect, and I'm going to mute mine now.
Okay, sounds great. Thanks for letting me know. So it's exciting to share after Dr. Phillip because she's talked about the baby-friendly hospital initiative. And I am delighted to share with the 4 team leads for our coalition. We've got this collaborative going, and they will be presenting as part of this, and we're going to go in order of zip code as opposed to alphabetical hospital name or whatever. So like Linda shared, I've had the opportunity to work in maternity OB nursing for a few years, and I've had the opportunity to work with Baby Friendly Team, and it's exciting to be part of the Minnesota Breastfeeding Coalition. So my slides aren't advancing. There it goes. All right, objectives, they're pretty self-explanatory, and we have no disclosures. So as a way of background or context, the Minnesota Department of Health has baby-friendly recognition, and they have 4 categories: maternity centers, work sites, child care facilities, health departments, and there's been a little confusion between the two. The work sites is really employee or staff focused, and when you think of Dr. Flood's sharing yesterday, supporting staff, or also when we hear from Betsy Yang today, supporting our staff and our employees at the work sites is that, but what I'm going to be talking about is actually the one that is patient focused, the maternity centers. And so the breastfeeding friendly recognition from the Department of Health is based on the 10 steps through the World Health Organization as well as Baby Friendly USA. And many state departments throughout the US have similar programs that are parallel or facilitate hospitals implementing these 10 steps, helping them move forward, helping them hardwire their breastfeeding practices. It aligns with Baby Friendly USA, but there are no fees through the Department of Health. It's not an all or none. You can begin working on steps in different sequences, as you'll hear. And when a hospital completes 2 steps, they can apply and they get 1 star. And the Department of Health ultimately has 5-star recognition. So what is the 10-Step Learning Collaboratively? This is work from the grant, and we began the project in 2019, getting organized. We had our cohort of 4 hospitals begin meeting late 2019. We met via Zoom before it became such a prominent part of our lives. So we had some of us had a chance to work with Zoom before we needed it. Anyways, and we as a cohort acknowledge the work that COVID has done to all of us. It's eclipsed some of our regular work, but also I have to recognize these 4 team leads and organizations have kept their passion for improving the care, implementing best practices at their hospitals. And it's exciting. The goal with being the cohort is that they complete 2 steps or 1 star of the Department of Health's breastfeeding friendly recognition program. So in the order of zip codes, Jennifer Klein from Northfield will share just briefly a little bit about their experience.
Yeah, hi. So I'm Jennifer Klein, and I'm the lactation consultant at Northfield Hospital. You can go again. You can go forward, Carol.
Yep.
So we're an independent community hospital in Northfield, Minnesota, which is in the southern part of the state. We have a newly expanded birth center that actually just opened officially October 1st of this year. And we do have about 500 deliveries a year. Our hospital and clinic system in caring for moms and babies consists of OBGYNs, we have family medicine doctors, certified nurse midwife, that program started just about a year ago, pediatricians, a neonatal nurse practitioner, and then lactation, which is also relatively new. And our team is Lisa Bauer, she's our center director, Sarah Gergens, our NP, Jamie Freelove is the clinical coordinator for the birth center, and then myself. And why we wanted to participate in this program is because the birth center staff work really hard to promote and support breastfeeding families. And we thought that applying and hopefully receiving this award would acknowledge their hard work and then also promote our hospital to the public. And we wanted to participate because our patients deserve best practices and deserve evidence-based care. So applying for and working towards awards like this help ensure that we are kind of staying on our game, aren't getting lazy, and just kind of, providing patients with the best services and the best information. And then, like Carol said, there was a glitch with COVID. There were several months where we didn't do any work, but we feel like we've come pretty far. And as of, you can flip the slide, Carol. Oh, I forgot. Yeah, the 2 steps we're working on are step 4, which are to help moms initiate breastfeeding within 1 hour of birth and to increase the skin-to-skin contact. And then step 5, so supporting mothers with breastfeeding, positioning, and also how to maintain lactation if they're separated from their babies. So what we've done so far are, as of October 1st, we've created assessment questions that were added to both the both the mom and the baby's electronic medical record, and that will help us collect data on how we're meeting those 2 steps. I've also started interviewing patients when I go in to see them in more of a conversational manner, just to answer those same assessment questions and to see how the patients are receiving the information that they get from the nurses. We've created patient education handouts on skin-to-skin, pace bottle feeding, handling and storage of breast milk, and safe formula prep that we can provide to patients. And those were all presented on our Staff Education Skills Day this past September. We started official data collection on October 1st. Hopefully I can have it completed by December 31st, and then want to apply in January.
All right, thank you, Jennifer. And we'll save questions also for afterwards. Then this is kind of a summary slide of the different steps that various teams have chosen. So thank you, Jennifer. And now Jeannie Freeb from Centric Care in St. Cloud.
Hi, everybody. Okay, well, I'm from Centric Care St. Cloud Hospital. I'm a registered nurse on IBCLC. I worked in the hospital setting for 39 years, and then this past year have transferred to the outpatient clinic setting. We became interested in baby friendly so many years ago and had thought about it, and the commitment to it, the money investment, and then the time investment is also, the cost. And do we have the resources? Do we want to do this? And I mean, we've talked about that off and on for years. And then a group of us were getting together for another meeting, and one of our nurse clinician, Melissa, she brought up this 10-star program, and we were like, oh, that's really interesting. And we thought we could do that. So we got our collaborative together, which is QI nurse, Epic nurse, 2 IBCLCs, a charge nurse, our leadership, and if I didn't say it, 3 providers, I believe we have. No, 4 providers we have. So that's our team. We've decided to work on steps 4 and 7. And what we did to gather our data is we developed a survey kind of question just to see how we were doing with steps 4 and 7 in a survey format. We're looking into how we can get some of our data out of our Epic, because we're on Epic, and we have expanded some of our Epic information to show our good work, and that's something that's good that's come out of our collaborative. We have enough data because we have so many births. We have about 230 a month average, give or take. So we need to have data from 20 patients, 20 to 25 in a month to meet the criteria. And we have had 2 really good months. There's a few other questions that are asked by the MDH that we're waiting for answers on. So we're hoping to get our first star in November. And we've just really enjoyed working on this. We hope to keep going. I think our next 2 steps, we want to strive for steps 8 and 10. And that's a little bit about us.
All right, thank you, Jeannie. And then the next will be Julie Nicholson from CHI St. Joseph's in Park Rapids.
Good morning, thank you. Like Carol said, I'm Julie Nicholson from Park Rapids, Minnesota, and I'm the director of OB care there, as well as one of 2 currently CLCs supporting our unit. We do about 120 births per year, give or take about 10. And I've been sitting here trying to think of how we even found out about this, this collaborative, but regardless, we decided to join. I am new to OB care, so I thought it would be a great way to learn more and get involved and see how we can enhance our breastfeeding skills. And so really our goal was to improve breastfeeding rates and education overall, very basic. And we started looking through the 10 steps, and we had heard about the 10 steps throughout this time through an OB manager group that we're in. And similar to other groups, the funding constraint and the amount of time that it would take to do baby friendly maybe just what hasn't been there for us. So this MDH collaborative gave us the opportunity to earn some stars. So we started going through these 10 steps and really found that we had a lot of work that we could do really from every single step. And so we tried to identify where we could really hone in our time and our skills. So lucky for us, we have a very involved CNO that supports breastfeeding. One of our midwives is also one of our team members, and then myself and one of the other nurses, the other CLC on the unit. So they really supported our time and energy into making some of these changes and encouraging us to be part of this group. So we started looking at really step 4, step 5, and step 7, and where we can take those. So where we're at right now, we have two more nurses getting their CLC via an online course right now. And what that will do to help us is spread out some CLC time into the off hours, into the weekend. The 2 CLCs that are there right now are myself and another nurse that works straight days. So we're really missing a big chunk of time and support for our moms. So the 2 that are working on it right now will hopefully support on other hours as well. So we're really looking forward to bring them on board to support our moms. Danielle and I, the other CLC right now, have been auditing and trying to see every breastfeeding mom that we have before their discharge. And right now we see about 90% of moms before their discharge that are breastfeeding. So those audits have been very, very good for us, and it's a lot of work, but we're both very committed to breastfeeding education. And then the other thing that we did was implemented more staff education. And back in January of 2020, before COVID and different types of meetings and things like that, we could still meet and do this excellent education. So we brought together all of our OB staff, as well as some postpartum, as well as the postpartum nurses, and brought them breastfeeding education. We did videos, we did scenarios, and talked about what was a good latch, what was a bad latch based on the videos, and some things that I had learned from my CLC education, and how to teach that. So that's gone over really well. And I think overall, we're starting to see our rates improve and our nurses to be more comfortable providing that education, but there's still always work to do. Like Dr. Phillip said, there's always a glimmer of things coming back, and we're quick to supplement, we're quick to give formula in the middle of the night when everybody's tired. So we're still working through some of those things. And now currently we're working with our IT to work on some standardized documentation for the 4 CLCs, so we can all be very similar in what we're documenting and how people are able to see that. And then the last thing quickly is our skin-to-skin practices. We've been really working hard on. We're great at vaginal birth skin-to-skin practices, but we found that we had some work to do in our C-sections. So we have spent a lot of time trying to develop how we could do our C-sections in the OR suite. Our units are not connected, so we're down in an OR off of the unit. And we have a general surgeon doing the cases. So just working together as an even bigger team to try to implement that skin to skin and how it all works. So we've done, we don't do a lot of C-sections, so we've only done 2, but both have gone fairly well, and we're learning lots as we go.
All right. Thank you, Julie. That's exciting. And last but not least, but because their zip code is last, would be Leslie Anderson, and she is from Lake Region Healthcare in Fergus Falls.
Good morning. Like Carol said, I'm Leslie Anderson, and I work as a labor and delivery staff nurse on our Women's and Children's Healthcare Center, and I also run the inpatient and outpatient lactation support program. We were very interested in joining this collaborative in order to conquer some of the steps for baby-friendly maternity care centers in Minnesota, and then also to conquer steps for Baby-Friendly USA. I've been involved in the SHIP grant since 2009 and have helped many businesses in the area become business-friendly or breastfeeding-friendly businesses. So we just thought it was a natural step that we bring our maternity care center to breastfeeding-friendly, since our hospital is already considered a breastfeeding-friendly business. We are working on steps 4, 5, and 10. And at this time, we are doing our chart audits to gather our data. We do about 350 births a year. And so our criteria is we have to have 80%, and we only have to audit 5 charts per month. So 4 out of 5 of those charts need to pass the criteria in order to be counted. I would say that Lake Region, we're a medium-sized hospital. With the size of our hospital, I think that was one benefit that we had. We have our own computer informatics department, and we can customize all of our own tabs and charting forms. We actually have a former OB nurse working in the computer informatics department who is an IBCLC, so she's my little champion down there. Whenever I need anything changed in our documentation, they are just right on that. So for step 4, we were able to add to our newborn admission record very easily. If baby was placed skin to skin for the first hour, or at least till the first feeding. For steps 5 and 10, we made small changes in our latch tab and in our lactation so that we could capture all the data that we do to support moms after they go home, and the education that they need to be documented in order to qualify as an accepting chart. As far as support after moms go home, we work very closely with our local public health agency. All moms get a referral to public health. We have a baby bistro in town that is a lactation support group, which was shut down for a while during COVID, but is now back up and running. And then our newborn outpatient lactation support, all babies come back 2 to 3 days after discharge to kind of fill that gap in between hospital to their first pediatrician visit. The first 3 steps that we wanted to work on, we felt that they were kind of low-hanging fruit, that we already did this work, that our nurses were good at it, and we just needed to be able to capture the data in our documentation. So that's what I would encourage facilities to do, and pick the easy steps first. Of course, with COVID, we had people in different roles, changes with how we did staff meetings and education, so that was a little bit of a burden, but I really think that now with working on more steps, how our nurses are navigating Zoom and WebExes, it may actually benefit us when we get to more education. We look forward to continuing with this collaborative. They're starting the 2nd phase, and so we would like to continue with this, pick a few more steps, and gain a few more stars to becoming a breastfeeding friendly maternity care center. Thank you.
All right. Thank you, Leslie. And what I think is interesting is the variety of hospitals from Greater Minnesota. And what is true is that these steps are still applicable to everyone. How you operationalize it is a little different based on how your organization is and who's there and what's happened, but it's still mothers, families, babies. How can we provide that evidence-based care? So the CDC grant was extended, and we have an open invitation for other organizations to consider joining our 10-step learning collaborative. There is going to be 2 informational calls in November, December. You can see the dates there. They will be the same call, and there's no commitment by just attending the call. If you are interested, you can email the Minnesota Breastfeeding Coalition Director, which is Linda Kopecki, who's done a great job of organizing and moderating and hosting this conference. But we'll then send you a link to attend these calls. Then if you are interested, we're kind of wanting you to have a commitment by the beginning of January and organize what it would look like at your hospital. There'll be some orientation and onboarding for your team, and you can hear more about that on the calls. So, you know, implementing all of the 10 steps usually results in higher both initiation and exclusive breastfeeding rates, as Dr. Phillip clearly pointed out. And I kind of look at it a little bit like a bundle, because I think we look at bundles in the hospital. So step 4 begins at birth with skin to skin, breastfeeding with that first hour. Step 5 is supporting moms with their breastfeeding positioning, common problems. Step 6 is giving no fluids other than mother's milk unless medically indicated. Step 7, rooming in, and I think it was pointed out that's for all babies. Step 8 is that responsive feeding with no restrictions, teaching mothers who choose to formula feed the skill to do that. And step 9 was to give no pacifiers or artificial nipples, and yet the World Health Organization and Baby Friendly USA are recognizing that it's really to counsel against that, or at least help parents understand the impact of pacifiers and artificial nipples in the hospital until breastfeeding is established. Step 10 is that bridge to support after discharge. And those together in the hospital are kind of a bundle. Step 3, that prenatal information, helping moms to understand the benefits to herself and her baby, her family, and then what to expect when she comes in. Step 2 is that education, so that everyone has consistent messaging of evidence-based care, and it's not my personal experience, my family's experience, what education I had 20 years ago. And then step 1 really summarizes it all together in your policy and how you work with that. So I think that it's multidisciplinary work. And I think Dr. Kim's quote yesterday was really thoughtful, that human milk really is the single most powerful intervention to optimize the best health outcomes in all babies. So as Dr. Phillip said, it's time to begin cutting the cake. We wanted to recognize current and hospitals that have historically been recognized as baby friendly, and or the Minnesota Department of Health's 5-star program. So I'd like you to enter into chat who are there that have done this work, because we want to celebrate what you've done. So, and it's a little busy, but if you take the time to study it, the circles are the hospitals that were birthing in 2012 but are no longer. The blue squares are the birthing hospitals in 2019. You can see the gold squares are hospitals that are designated baby friendly, and that is a rigorous designation, as Dr. Phillips alluded to. There's 14 hospitals here in the state. Then historically, we have had 7 other hospitals that achieved baby-friendly designation. Mayo Clinic Health System in Austin was the first in Minnesota. mHealth Fairview at Masonic Children's was the first in the metro. And you can see the other hospitals. Then currently, it's been about a year that the Minnesota Department of Health 5-star rating is for the Community Memorial Hospital in Cloquet. And you can Google Minnesota Department of Health to learn more about this program. And then last, our current 10-step learning collaborative, so you can see where we're from. Centric Care is in St. Cloud. CHI St. Joseph's is in Park Rapids. Lake Region in Fergus Falls, and then Northfield. So it's from the greater Minnesota area, which is exciting. But we've got some ways to go with also hardwiring those 10 steps for breastfeeding in our state. And then last, let's cut the cake and celebrate what great work has been done and what we hope to do in the future. And I thought the fruit looked great, so this is my choice of a cake. So I'm going to stop my sharing, and then we can look at what questions there are in chat or comments.
Thank you, Carol, so much. This is really exciting for all of us. And I just want to remind you, anybody who's working with a baby-friendly hospital or was part of that process, please mention your journey in the chat section. We want to celebrate you and acknowledge you. One question for all of the folks in the 10-Step Learning Collaborative in the Q&A was really the relationship between the 10-Step Learning Collaborative and Baby-Friendly Hospital. So are there plans for these hospitals, for you in these hospitals, to pursue baby-friendly? What is, or is this a stepping stone towards baby-friendly? What's that relationship, personally or in general?
Hi, this is Leslie from Fergus Falls. We have a new CNO in our facility and a very supportive nurse manager and our CNO is very up on becoming baby friendly. So I would assume, as we complete a few more steps and that journey gets a little bit closer to intuition, we'll be going down that road also.
Great. Anybody else from the collaborative want to respond? And maybe you don't know, but
this is Julie from Park Rapids. At this point, I don't think we know. It's really a stepping stone for us right now. I think there's a lot of factors that we'd have to consider, and we have a great support team, but the cost and the time and the staff that are needed to pull something like that together is really something that we don't necessarily have right now. So maybe sometime in the future if things were to change for us.
Excellent. Thank you so much.
Oh, this is Jennifer Klein. Yeah, I would say the same about Northfield Hospital. Just kind of echoing what Julie said about her institution.
So I have there's another question in the Q&A, and I'm not really sure who will be able to respond to this, but there was the listing of the historic baby-friendly hospitals on that map. And so they're no longer baby-friendly, but they have been in the past. Is there tracking of breastfeeding rates continuing for those hospitals? I don't know who can answer that.
I'm not sure how to answer that one either. Yeah. I think maybe Marcia could see a little bit through the state data, possibly.
There might be, and it might be in the chat section that somebody responds, because there may be an attendee who works for one of those historic baby-friendly hospitals. Marcia, do you want to respond?
I would say that, yes, we do have breastfeeding initiation in Minnesota hospitals, but we currently don't publish anything by hospital. So it's not really publicly available data at this point. I'd love to see that happen, but
Bobby's reminding us that in the chat section that if they are accredited by Joint Commission, then they have to report rates.
And
yes,
and I will.
Right, that's what I was going to say. This is Pam. Yeah, that all of the hospitals that previously were baby friendly are Joint Commission hospitals. So there's a requirement to report exclusive breastfeeding rates. So that will continue. And I think that's a really important piece of data to keep tracking.
And what I meant was that the Minnesota Department of Health does not receive that data at this point, and we don't publish it. The exclusivity rates we don't get, and the any breastfeeding in the hospital, we have it, but it's not published anywhere right now.
So I think the specific question, and the person who asked it clarified, is if they are historic baby friendly and they're no longer designated, has that resulted in decreased breastfeeding rates?
I can't answer.
Yeah, I don't think we have an answer for that, but it's an interesting question and maybe something to look for.
But I do know at the time that there was move towards baby friendly, we did see both initiation and exclusive rates improve. I can't tell you statistics or numbers though.
Okay. So thank you so much, everybody. And this is such a wonderful celebration of all of the work that we're doing in our hospitals. And I just want to say it's time for a break. We're going to have a quick break. I know Pam Heggie wanted to mention something. There was that robust conversation about circumcision and setting, and I'm going to pass it over to her in just a second to comment quickly on that. We're going to have a 5-minute break. We'll be back at 10:05, and we're going to start with a video from Betsy Yang. We've had a few of our medical providers, Betsy's an RN, just share their journey with breastfeeding. This one's a little bit longer. She's a little soft-spoken, so you may have to adjust your volume. But I thought this is appropriate for today as we're talking about the hospital environment and the hospital culture. And I'm going to pass it. I'm going to pass it to Pam, then I'm going to stop recording because I also want to identify the one phone number that we have, because we need to match you to a person to be able to make sure that you have you get credit for attending the summit. So Pam, why don't you comment quickly on circumcision and setting?
Okay, so I just wanted to comment about the circumcision question. People were wondering about if there were hospitals that were doing circumcisions as outpatients. And there really is a trend to have circumcisions done after babies go home and not have them in the hospital. That was initially driven by medical assistants in Minnesota not paying for circumcisions, and so the families needed to pay for them. And also, it's well known, and there's been observation that babies feed better if you wait on the circumcisions. The one caution about that is that at the University of Minnesota in particular, where their circumcisions are all done outpatient, it was being done at the same time as baby friendly. And so people actually started to assume that baby friendly prohibited circumcisions, and that actually increased the pushback about baby friendly. So it's just a caution when you're talking about circumcisions and you're talking about baby friendly and breastfeeding to try to have that be a separate conversation. Definitely waiting, just like waiting on the bath, can help with feeding, but it can be confusing, and just a caution about that. And I can talk with folks about outpatient circumcisions that we do in our clinic at Central Pediatrics. One other quick thing, Bobby Phillip had, you asked us how we're doing about banning the bags here in Minnesota, and we're doing great. We're doing better and better all the time, and our hospital survey is something that's going to be talked about later this morning. And you'll see we ask hospitals every year before our summit, do they have free formula, discharge bags, or coupons, and do they pay for formula? So stay tuned. We'll be talking about that more. So now it's time for the break.
Thanks, everybody. I'm going to pause the recording, and then the one person who's phoning in, I'd love for you to unmute yourself so we can identify who you are and match you to a name. Okay, I just want to, this is Linda Kopecky again. I want to welcome everybody back from the break. As we start the second half of our morning and the fourth quarter of the summit, I wanted to begin with a testimony by Betsy Yang. We know that storytelling is important, especially important with breastfeeding, because we have data on breastfeeding, but it's really the family's stories and their experiences that give life to the data. So we have some storytelling from folks in Minnesota. Betsy Yang is a nurse at one of our area hospitals, and we learned about her story about 1.5 years ago when we were members of the Minnesota Breastfeeding Coalition and what is now the new Hmong Breastfeeding Coalition. We're interviewing Hmong healthcare providers about how they experienced breastfeeding themselves or either with their community. And her story has really stuck with us, and so we wanted her to share it with you. And you may need to adjust your volume. She's fairly soft-spoken and it's a little bit longer, but it's a really important message.
Hello, my name is Betsy, and I am a registered nurse at a Twin Cities area hospital. I would first like to thank the Minnesota Breastfeeding Coalition for allowing me to come and share my experiences as a healthcare provider who was also breastfeeding. I am a first-time mom who was able to breastfeed my daughter till the age of 14 months, which seemed like a huge feat. With all the breastfeeding challenges that we encountered. But sometimes I find that as a nurse, you're kind of, as well as a doctor, I feel that people feel like you should have all experiences across all disciplines of healthcare. But I have to admit that OB, labor and delivery, and postpartum were not part of my wheelhouse. In fact, I think the last time that I took care of a postpartum mom was nursing school. So my husband and I decided, after doing some research, that we really wanted to try to breastfeed our daughter. You know, bonding and cost savings, and also the health benefits were really what led us to feeling like this was really important to us. So my daughter made her debut about 4 days prior to her induction day, halfway through my 12-hour night shift while I was monitoring a patient who was requiring emergent cardiac catheterization. So it was a long 10-minute waddle to the labor and delivery department, much to my husband and my surprise. The rest of our delivery was pretty uneventful. It was a blur, and after our daughter was delivered, the nurses encouraged us to do skin to skin and also breastfeed. And I thought that the first 24 hours I was doing a pretty darn good job. So we were allowed to discharge at the 24-hour mark, but right before we discharged, the lactation nurse came in to see us, our lactation nurse, Evelyn. And Ellen came in and she observed us kind of breastfeeding, watching our daughter latch on, kind of showing us techniques on holding her. But afterwards, Evelyn delivered some pretty distressing news. She pretty much said that in the last 24 hours, our daughter had not received a single drop of milk. Our daughter was, in fact, tongue-tied, and all of my efforts in the last 24 hours yielded nothing for her. So instant mom guilt. I pretty much cried because I couldn't even provide my daughter the most basic of needs. So Evelyn had our nurse bring in some donor milk, and it asked for us to stay another night so we could feed our baby, which we were gladly to. I wanted just to talk a little bit about our experiences with having a daughter who's tongue-tied, because I think it touches on one of the objectives of the summit, and that's supporting unique aspects of breastfeeding in each discipline and nursing. And so prior to us finding out that our daughter was tongue-tied, we kind of just thought this was a condition that affected speech and not so much something that would affect her breastfeeding. So when we discharged from the hospital, because our baby was slightly jaundiced, we did have pretty frequent doctor visits in her first couple of days of life. And we had mentioned to the pediatrician that our daughter was tongue-tied according to the lactation nurse. Now, our doctor did bring in another doctor to help assess, but they both kind of said, nope, your daughter's fine. She's not tongue-tied. And we went home kind of feeling really discouraged. Like there was this discord between what the lactation nurse had said and what the doctor had said. And we really kind of felt discouraged as new parents, not really knowing what we were doing. we continued to see our lactation nurse kind of through all of this to make sure that our daughter was getting enough milk and gaining weight. And she encouraged us to seek this dentist who had specialized in frenectomies. And at 10 days old, we took our daughter in and had her frenectomy done. And this time was really difficult for us because we felt like there was a lot of really disjointed information from what our physician was telling us, from our lactation nurse was telling us, from what the dentist was telling us, and it was quite frustrating. So it kind of felt like there was like this pull and push between discipline versus collaborative care for what was in the best interest of our daughter. Now, I wanted to speak on something that has been on my heart lately, and I don't know what we would have done without Evelyn and our lactation nurse. I don't know how many ounces our daughter would have lost or how many days would have gone by before someone would have noticed that our daughter had not been eating. So in this difficult time of COVID, I know that hospital leadership has had to make some pretty difficult decisions. But I want to emphasize that our lactation nurses are essential. I can't imagine going through our experiences, and I can't imagine all the new and scared moms right now in the time of COVID that are going through this without the love and the support that only a lactation nurse can provide. So again, I stress our lactation nurses are essential. I know that our lactation nurses at the hospital I work at have been furloughed. So just a little side note. Now to the task at hand. How can we support healthcare providers who are breastfeeding? So I thought back about my experiences, and I asked other coworkers kind of what they were going through, the difficulties they face when they're breastfeeding, and we kind of summarize it in 3 different things. One is breaks, and not so much just the lack of breaks, but really uninterrupted breaks and scheduled breaks that maybe don't have a flexible time. Number 2 would be availability of places to pump. And then 3 is really lack of support from other team members and coworkers. So when I went back to work at 4 months, I worked as the critical care flyer, and my role kind of consists of responding to codes. I work 12-hour night shifts. Now, the really unfortunate part is that usually I'm the only one on, and so when I am pumping, I'm unable to have someone really fill in for me. So when I am pumping, I'm pretty out of commission. And it's really quite disruptive to try to pump and get to a place where you're relaxed when your Vocera's going off or your pager's going off or your cell phone's ringing, to really find the time to relax and pump. So I remember one night in particular, I had just started pumping, and they called the rapid response team. So I tried to finish up as fast as I could. And I decided that it was too far to take my breast milk from the lactation room all the way up to my break room, and then walk all the way to where the code was happening. So breast milk in tow, here I am trying to get to a code. And when I got there, the code was pretty much over and everything was fine, but I was later asked about my tardiness to the code. And I said, I was pumping, and I tried to get there as fast as I could. So these uninterrupted breaks, really being able to step off the floor and feel like I can go away, take the time to pump, and not feel like I'm abandoning my coworkers who are doing patient care, that now that I need to take this time to pump, that I've left them high and dry. That's a really tough feeling to carry with you when you feel very torn. Do I feed my baby or do I work with my coworkers? So that's definitely one thing, is these uninterrupted breaks. The second thing I've noticed is these scheduled breaks. So due to unit needs, there's these breaks that are scheduled, and sometimes you're scheduled to go on a break like 2 hours after you've arrived. So now you're pumping before you need to pump, and you're at the 2-hour mark, but you have 6 hours left, and you can't go take another break. And that is really difficult. I mean, that affects your breast milk, the supply, and then really the pumping time, the pumping schedule that you've kind of set up at home is now a little bit off. So the flexibility of break is important, in addition to the uninterrupted breaks that are really hard to get. Now, the second thing that I find that is kind of a barrier to pumping is definitely lack of place to pump. So I work at a hospital that has like 325 beds, and our lactation room is able to accommodate 3 moms. So at one point in the department, another mom was also breastfeeding, and so just the 2 of us had already taken up 2/3 of the space. So I have had other nurses tell me that they're pumping in bathrooms, in linen closets, because either the location is too far or just really the lack of time makes it too difficult to go down, get your pump, and eat at the same time and get back upstairs. So really the lack of place is really difficult. But I think one of the other things, and then the third thing that I find is really difficult when it comes to being a breastfeeding healthcare provider is that even though we work in the healthcare industry, there's not a lot of understanding and patience for moms who do need to take time and pump. I remember one night in particular, I was working with somebody, and I had it had been about 4.5 hours, and I was telling them that I need to go pump, and they scoffed at me, and I felt really discouraged. And so I decided I'll just quick do my task until I can find some free time to go pump. You know, by the time I finally got to go, we were looking at like 5.5 hours now. And then I pump, and what that also does is then it puts back my schedule for when I have to pump at home, and now I'm up later than I should be versus just going home and sleeping. So, you know, we get annual education on breast pumps and restraints and glucose monitors and customer service, but in the 10 years that I've been at my hospital, I don't remember any education that really, you know, has to touch on the topics of how do we support breastfeeding moms. So how do we support our breastfeeding moms or our healthcare providers who need to pump? I would say first, listen to the staff, heed their concerns, give them ample of time to pump. Let them do it without shame, without feeling like they've completely abandoned their coworkers because they have to leave and pump. Like I said, we encourage this with the patients that we care for, but completely negate this with our own staff. Provide maybe education. It doesn't have to be annually, but maybe every 5 years, every 3 years, to maybe include the importance of supporting and the inclusion and supporting these moms and these providers who are breastfeeding and require pumping. And I think lastly, you know, provide space where we can safely pump, and do know that when we do pump, you know, we can do it and relax and kind of not feel torn between feeding our babies and caring for our patients. So again, thank you for allowing me to share my experiences as a breastfeeding healthcare provider. I will conclude, as every recording I've tried to do now has not been under the time mark. So again, thank you for allowing me to share my experiences so much. Have a good one.
So thank you, Betsy. Thank you, everybody. I just wanted to see if anybody has any reflections on that. Share my video, and feel free, other panelists, to share your videos. We'll just take a couple minutes and see if anybody has comments or reflections on Betsy's message and or her testimony. Please speak up in the chat section too.
This is Julie Nicholson from Park Rapids. I can relate to her in so many ways. I'm a new mom as well as a healthcare provider. I work as the OB director, and I feel all of her feels trying to do all the things and find time and being torn, and it's so hard. And I find myself some days I will go see a mom about breastfeeding instead of taking care of the pumping that I need to do too, because you're just torn between those two things. So I have felt all those feels for those videos the last couple days.
Somebody mentioned in the Q&A that she made so many great points regarding breastfeeding as a healthcare worker. Definitely. In the chat section, it was beautifully done. I feel like the story is one that this person who is, so Ann Oswood mentioned this, and she's on the board of the Minnesota Breastfeeding Coalition. She's a nurse midwife, and she's an IBCLC, and she said that she's heard this many times. Just wondering if there's any other reflections or comments. So thank you, Betsy, for your honest and heartfelt testimonial. We'll be continuing on now. Just quickly, somebody in the chat section said that the disconnect between providers, which are pediatricians, lactation consultants, et cetera, is so important and problematic. The many messages that she was mentioning between the different disciplines, that can be very challenging. So I'm gonna go back to this. Our next segment is about our Rhonda Skelton Above and Beyond a Maternity Care Award. This is something we've been doing for a number of years. I'm going to pass this along to the current chair of the Minnesota Breastfeeding Coalition, who's Katie Galloway, who is my partner in crime and my colleague, and I think she's my friend. And I'm so glad to be working on the leadership at the Minnesota Breastfeeding Coalition with you, Katie. But I'm going to pass this to you. You can use your video or not, but Katie's going to present the Rhonda Skelton Award for 2020.
Hi, can you hear me okay?
Definitely.
Okay, perfect. Thank you so much, Linda. And yes, we are definitely friends. In addition to colleagues with the Minnesota Breastfeeding Coalition. And so it is my honor today to talk a little bit about the Rhonda Skelton Above and Beyond a Maternity Care Award, as well as presenting this award this year. And so I just wanted to share a little bit of background about this award before we go into announcing the awardee. So the Rhonda Skelton Above and Beyond a Maternity Care Award is presented by the Minnesota Breastfeeding Coalition and Healthy Northland to honor the memory and work of Rhonda Skelton. Rhonda Skelton was a dedicated nurse and manager who worked hard to make hospital maternity practices baby-friendly. Rhonda directed the obstetrics department at Moose Lake's Mercy Hospital, where she had worked for 25 years. She was passionate about breastfeeding and early contact between a mother and her baby. For 10 years until her death in November 2016, Rhonda worked doggedly going above and beyond in her efforts for the hospital to achieve baby-friendly designation. At the time of Rhonda's death, 1 year remained for the hospital to meet the requirements to obtain the baby-friendly designation. And as a testament to her dedication and commitment to nursing mothers and babies, the nurses at Mercy Hospital, who all were inspired by Rhonda's vision, followed her example and continued tenaciously to finish the hard work that Rhonda started. The first Rhonda Skelton Award was presented in 2017, the same year that Moose Lake's Mercy Hospital was designated as baby-friendly. The award recognizes a maternity center administrator or staff member who has shown dedication above and beyond implementing maternity care breastfeeding best practices. And I just want to share something that Laura Skelton, Rhonda's daughter, wrote about her mother. Rhonda Skelton was a loving mother, wife, daughter, sister, and friend, as well as a caring, hardworking nurse who went above and beyond for her staff and patients. Between the stressors of being a manager, mother, and wife to an ill husband, she always remained strong and would do anything for anyone. The sacrifices she made will be remembered forever, which include the sacrifices she made for my dad. I hope this award honors who she was as a medical professional, but also who she was as an incredible person. The 2020 award nomination requests were sent to Minnesota hospitals and posted on the Minnesota Breastfeeding Coalition website. There were 4 amazing nominees for this award, all easily meeting the qualifications. And I was honored to be chosen as one of the reviewers of these nominations, and I can attest to the fact that these were all great nominees, and it was definitely a difficult decision to choose between them. We want to thank the other reviewers that took their time looking at these nominations, and also to those who took the time to complete and submit the thoughtful nominations on behalf of these other individuals. And we also want to thank and acknowledge the hard work of all of the nominees for their ongoing efforts to make breastfeeding easier in Minnesota. So with that being said, I'm very honored again and just really delighted to announce that there was actually a tie this year. So there are going to be 2 people receiving this award. And then we will get these awards mailed out to the awardees here later on. But if you want to go ahead and advance the slide, I am happy to announce that this year's awardees for the Rhonda Skelton Above and Beyond in Maternity Care goes to Jeannie Freeby and David Walls. So bear with me, I'm going to continue to read a little bit more about both of these awardees because I think it just is a true testament to the work that they've done, but also I just want to highlight some of the things that the individuals who nominated them shared about them, just to kind of give you a little bit more information about who they are and what they've done. So first, for Jeannie. Jeannie has, and this was again according to her nomination. So Jeannie has worked as an IBCLC for 20 plus years at the St. Cloud Hospital. She has been a bedside LC and postpartum RN, as well as an outpatient consultant within the hospital setting until 15 years ago. That program was eliminated due to budget constraints. Jeannie has been instrumental in the success of our lactation consultant services at the hospital, working to educate staff, providers, and orient new staff to the birth center. She is part of the Breastfeeding Coalition, guiding us towards Mother Baby's 10 Steps collaborative success, and has helped to organize the Big Latch On for Central Minnesota. Jeannie has successfully launched the first milk depot in Central Minnesota 2 years ago, and it continues to gain speed and success with Jeannie's continued commitment to breast milk feeding for as many families as possible. Jeannie, along with birth center leadership, proposed a new lactation resource position to support prenatal and postnatal mothers at the Centricare OB clinic, which was approved in January 2019. There she sees mothers prenatally to educate on the importance of breastfeeding, but also educates those who are interested in pumping to bring colostrum to the hospital when they arrive to give birth. Jeannie has helped us reach success with Skin to Skin, honoring the golden hour, 24-hour rooming in, where we only have access to procedural nursery during the day, and hundreds of satisfied patients and families who have been lucky to receive the expertise and support Jeannie provides. Congratulations, Jeannie, on behalf of the Minnesota Breastfeeding Coalition and Healthy Northland. I would like to present you with this award and thank you for your dedication and inspiring work. And like I mentioned, oh, go ahead.
So I just want to say, this is Linda again. I've asked Jeannie and David if they want to share their videos and share their mics so they can speak after you just introduce both of them or even between. But it's up to them if they would like to say something, but they have the opportunity to do so.
Great, thank you. I am going, Jeannie, did you want to talk now?
Sure.
Perfect.
Here I am. Hi, everybody. This is such a great, well, it's a big surprise to me because I nominated the other person that won. But Boyd and Melissa Lane nominating me, that was awesome too. And there's just so much opportunity I've had to grow and keep growing and helping those I work with to help mothers with meeting their breastfeeding goals. Being part of the Milk Depot, the Minnesota Breastfeeding Coalition, also helps me grow, stay connected statewide. I've met so many amazing people there. and I hope to just keep doing good work. It's just, I've really latched onto it. Wink, wink. But thanks for the award.
Definitely well deserved, and I love the fact that Jeannie kind of alluded to it, that she actually nominated David, and so it's kind of a testament that both of these individuals are from the same organization, and just how it's so critical to have support and a good team to kind of move some of this work forward. And so I'm just going to read a little bit from the nomination for David. So Jeannie wrote, Dave is the Senior Director for our birth center. He has shown his dedication to maternity care, breastfeeding best practices, most of all by the support he provides to our frontline staff who work directly with our patients, both in clinic and in the hospital. Examples include lending financial support for staff for breastfeeding education, certification, and actively participating in the 10 Steps cohort, which aligns with the 10 Steps to Successful Breastfeeding in the International Code of Marketing of Breast Milk Substitutes. And many other ways he demonstrates willingness and commitment to support other staff and patients in providing breastfeeding services by attending our local coalition meetings, reaching out to the community through supporting our baby cafe, partnering with our public health services, supporting our annual Big Latch On event, and supporting the efforts and work to start our milk depot. He stays connected with our providers and other leaders to support breastfeeding both locally and beyond. He demonstrates going above and beyond by attending our local coalition meetings, joining our monthly calls of the 10-step cohort, and he stays engaged and listens to staff and patient feedback and follows through. He takes phone calls and replies to emails in a timely manner, even though he is really busy at his level of work. He takes the time for you. He generally cares, and it really shows in all his work with all he comes in contact with. David is open to new ideas. He is not stuck in the same old, and he supports best practice. He motivates others to believe in their goals and to strive to achieve them. And he is transparent, approachable, and positive. So again, congratulations, David. On behalf of the Minnesota Breastfeeding Coalition and Healthy Northland, I would also like to present you with this award, and thank you again for your dedication and inspiring work.
Well, thank you so much. Hopefully you can hear me okay.
Yes, yes.
I am totally honored to receive the award, and especially in the same sentence with Jeannie Freebie. She's an amazing nurse. Not having the privilege in meeting Rhonda, she sounds like an amazing leader, caregiver, wife, mother, and a real trailblazer in breastfeeding initiatives. And her daughter writes, an incredible person, and she sounds like that. So thanks for keeping her spirit and her passion alive through this award. Much like Rhonda and Moose Lake Mercy Hospital, St. Cloud Hospital, Center Care, we're doing some great things, led mostly by Jeannie, but there's a lot of key people within Center Care that does great things. The saying, it takes a village to do great things, and that's the case here as well. And I'd love to shout out to Melissa Lane, Diane Pellant, Jackie Hoytja, Melissa Bruns, Heather Klein, Kim Walbert, our amazing lactation consultants, and other lactation experts in our OBGYN clinic to make this possible. And lastly, thank you to the Minnesota Breastfeeding Coalition in selecting, myself and Jeannie for this amazing recognition. And like Jeannie and others say, we will continue to hopefully latch on best practice in breastfeeding and lactation. So thank you so much.
So thank you all. Thank you, Katie, for presenting the award. Congratulations, Jean. Congratulations, David. I'm so grateful for all of your work in advancing breastfeeding in Minnesota. We're going to move along, and the next presentation is something we do every year, our hospital survey. And we have a student who's Elise Haven. She's a student in the Maternal and Child Health Department of the School of Public Health at the University of Minnesota, and she'll discuss the hospital survey, and then we'll have Marcia McCoy, who is actually her supervisor. At least is Marcia's intern, and Marcia is I've known Marcia for a long time, since we were the legislative leaders about 20 years ago. And so Marcia is now with the State Health Department. She's an epidemiologist for WIC, and she has done quite a bit of work in the past few years with disaggregating our breastfeeding data by ethnicity, and that's done quite a bit towards for some of the racial reconciliation in our state. So thank you so much. But she'll be discussing some of the new COVID breastfeeding data, COVID era breastfeeding data. So I will stop sharing, and Elise, you can feel free to begin your presentation.
Thanks, Linda. Let me just share my screen here. Alrighty, can everyone hear me okay? Hopefully that's good.
Yes, definitely. Thank you.
Great. Thank you. Hi, everyone. My name is Elise Haven. I am a Master's of Public Health candidate at the University of Minnesota School of Public Health. I am in the Maternal and Child Health program. And this summer I had the privilege of working with Marcia to disseminate and analyze the results of our 2020 Minnesota Hospital Infant Feeding Practices Survey. So I will just be doing a brief overview of that survey and our results, as well as discussing the biggest barriers that we found to our hospitals and clinics achieving that baby-friendly designation. Okay, so the Infant Feeding Practices Survey is a yearly survey that is disseminated to our Minnesota hospitals and birthing clinics to gauge their level of baby-friendly initiatives. We create the survey in SurveyMonkey and send it out through a listserv of our OB nurse managers and lactation consultants at each hospital through MailChimp. However, this year, most of our surveys were complete after a few rounds of email reminders and lots of phone calls and over-the-phone surveys. Initially, we had intended on having these survey results a little bit earlier in the year, and then our lovely friend COVID came around and kind of threw some disruption into that. So we ended up disseminating the survey and getting those results back through the beginning of the summer. And then we worked through the rest of the summer to analyze these results. Some of the important topics that we were looking at this year were which hospitals were working on the 10 steps to successful breastfeeding. Are these hospitals offering donor milk, and do they have milk banks? Are they designated as baby friendly? And again, what are the biggest barriers to becoming baby friendly? So this just highlights some of our results, and we see here a little bit of a change from 2019 to 2020. So we saw an increase in hospitals and clinics that had an infant feeding policy, an increase in newborn exams that were performed within the mother's room, use of donor milk, and having a milk depot, which were great. And we noticed decreases in hospitals paying for formula and providing mothers and families with discharge bags that included formula and information regarding formula. And these are our results spread out from our 2014 results through 2020. So again, we see those same kind of patterns between 2014 and 2020, but with slightly bigger differences over the years. The biggest thing that we wanted to highlight were the barriers to becoming baby friendly. And I think that these have really been highlighted already during the summit, especially with Betsy's talk. She really was able to give some personal testament to those. So I'll go over some of our biggest barriers that we found were answered in the survey. So most importantly, we wanted to touch on barriers that they faced within their baby-friendly practices and policies. And the largest barriers were finance related, of course. So the cost of training and site visits were very expensive, followed by a lack of reimbursement for the lactation services. So there's a very clear financial barrier to these processes. The next strongest barriers were related to staff support and client preferences, which we just heard a lot about. There seems to be a really big disconnect between the knowledge that we have, but then the resources and the support that we're providing for mothers who are breastfeeding, as well as employees who are breastfeeding. And we found that about 56% of our hospitals noted that physician and staff resistance were significant barriers, and that 53% of our hospitals said that client preferences were a significant barrier. So I think that these can be addressed really well through continued education for mothers and also within our hospitals and clinics, and increased support, making sure that we bridge that gap between the education that we are providing and the support that we're giving. A little bit of information on our donor milk. As for donor milk, we've seen small decreases and increases over the past few years in the use of donor milk. In 2017, 40% of our hospitals used donor milk for babies needing supplementation. And this year in 2020, 39% of our hospitals were providing with that. It's also important to note that our results could have been greatly affected by COVID hitting many hospitals and mothers and families, and that this provided a really particularly large barrier in 2020 to these results and to our progress overall. And as a brief summary, we found overall that our hospitals are making small but positive improvements to becoming baby friendly. Again, COVID-19 may have played a large role and an unexpected barrier to even more improvements that we could have potentially seen this year. Regardless of the pandemic, there are several large institutional barriers to becoming baby friendly that include finances and staff support, and client preferences as well, which hopefully will be improved again with continued education and support for our mothers and babies. That's the information that I have. I'll turn it over to Marcia. I just want to thank the Minnesota Breastfeeding Coalition for having me today, and thank you to Marcia for mentoring me this summer and guiding me through this project. Thank you.
Marcia, we can't hear you. Your microphone is on, but I'm not sure why we can't hear you. There we go. Oh, nope, not. Do you have a faulty connection?
All right, can you now hear me?
Yes, we can.
Okay,
yes.
great.
And feel free to share your
my
screen.
wireless, it's a little odd sometimes. So,
okay.
So I originally was going to continue the discussion on the infant feeding practices survey, but because of what's going on currently, I am instead doing a tiny pop-up presentation of breastfeeding, what we're seeing in the Minnesota WIC program during COVID-19. And I am going to go through these slides really quickly, but I want to make sure I at least get this information into the hands of attendees, and you can hopefully look at them more in detail on your own time. And before I start, I did want to thank so much Elise Haven for her work on the infant feeding practices survey, because in prior years we've had more staff time and more student help to do these surveys, and this year Elise really took it on as she took on the major burden of getting it done. So thank you so much. So because of concerns about what's happening during COVID-19, we in the Minnesota WIC program have started tracking breastfeeding on a monthly basis and trying to look at the numbers more quickly. And I wanted to mention that we have a couple of online resources that people can look up. These links are on these slides. And the first is Breastfeeding During the Current Health Crisis, which offers information for families about safely initiating and maintaining breastfeeding, no matter what your COVID-19 status is, or whether you've been exposed or had COVID or do not have COVID. So it's a great resource to share with parents. And then we also have a fact sheet about what we're seeing in the trends for breastfeeding among Minnesota WIC participants during COVID-19. And the next three slides I'm going to show you are directly from that fact sheet, so you can look at them more in detail also online. So what we're seeing is that we've had some downward trends happening with Minnesota WIC participants in 2020. We were kind of hopeful that it was recovering in May, but over the summer we saw some further decreases that we're concerned about. And we also saw in the early time of the pandemic that the in-hospital supplementation that was being reported to WIC actually was going down. But unfortunately, it has rebounded and is higher than pre-COVID levels at this point. And the supposition is that this is probably because for a while they were doing a lot of early discharges, and a lot of the hospital supplementation happens on the second day in the hospital, not in the first 24 hours. So that's the speculation about why we might be seeing this trend. And what we also looked at is what is happening by race and ethnicity and cultural identity with breastfeeding. And you'll see that most of the groups that we track have had some decreases. The largest decreases are among our white participants and among our Black African American participants, where we're seeing some really concerning downward trends in. And this data we are reporting quarterly because we need large enough numbers to be able to see the trends clearly. So now I'm going to show a little bit of data that I actually finished just a couple of days ago because I have been able to get a hold of a partial birth certificate file for 2020 thanks to COVID. And so we can take a look a little bit at what is happening in 2019 and 2020. So on this chart, the dotted lines are 2019 and the first 3 quarters of 2019, and then the solid lines are the first 3 quarters of 2020. So you can compare where each of these groups was in 2019 compared to this year. And you can see that especially if you look at the purple, which is white with participants, you see this divergence where there's really a concerning drop-off, and you see the same pattern with American Indian families and with African American Black families. And we also see that there is somewhat lower reporting of breastfeeding among other groups, although it's not quite as dramatic. And we have one bright spot, which is that the Hmong community has, their breastfeeding rates have not moved much due to COVID, so take from that what you will. And then I also just finished looking at breastfeeding rates by region, and so I'm not going to really go through these, but I provided historical for the 4 quarters of 2019 and then the first 3 quarters of 2020 so that you can look and see what may be happening in your region. And there's definitely big differences in what's happening with the trends, depending on what region you're in. So I'm sorry that was so quick, but it's kind of like late breaking news. So I don't know, Linda, do we have time for any questions now or about the survey or this, or?
I had one question in the question and answer. It was just, are these slides being shared with us? And the answer is yes. With that, Monday, my promise for Monday to send all the recording, to send the PDF of all of the slides, because I think I have the most updated slides from everybody by now.
Yeah, and my apologies for not having them out, but like I said, I needed the birth certificate data in order to get to properly be able to pull out the Hmong and the non-Hmong Asian apart, and to pull the East African and the Black apart. And so this, literally, I did not have this done until.
And I just have to mention that some of the disaggregation of data that we've been doing with breastfeeding for the last few years, and Marcia, that's actually the origin of your position with the Minnesota Department of Health, was to start working on that project. And I have to say, in communication with other states, that we're quite the envy of other states, but the diligence and that we disaggregate the data by ethnicity, and I think it's something that we can really be proud of. It does make steps towards some of the racial reconciliation that we're looking at and we're working towards, is not having groups in the other category. There is no other. We're all, every group has its own path, community has their own path, their own history, their own experiences, and really highlighting that and disaggregating the data is very important. So thank you so much for all your work.
And I would like to mention too that now that I have the birth certificate data, what I'm seeing with that is that it's not having the same dramatic decreases as we're seeing among WIC participants. So what may be happening with this story is that the people who are not on WIC, so people of a higher socioeconomic status, are actually doing better with breastfeeding, even as people with more challenges in the WIC population are doing worse. So what we may be seeing is a widening disparity, not a racial disparity, but a economic or class disparity widening. And in Minnesota, we already do know that the disparities between people of different economic classes are even broader than the disparities, the racial disparities we have. So.
Thank you so much. I mean, that highlights another thing that I know that we try to do in Minnesota, is when we see something that is doesn't make sense, some of the data that doesn't make sense, we approach it with curiosity. And why are the stories that we're hearing different from the data that we're seeing? And then we approach it with curiosity and we learn more. So thank you so much. I'm gonna move along. It's starting to feel like it's all Centricare all the time today, but with our Rhonda Skelton Award winners and then our next presentation. But obviously Centricare is doing some amazing work. And I just want to quickly introduce this team. It'll be 2 different presentations, and we'll take questions after the 2 different presentations. So Melissa Lund is the director of the Birth Center at St. Cloud Hospital. Melissa Bruns is the regional outreach educator for women's health at Centricare, and Diane Pellant is director of the NICU and the Family Birthing Center Integration and Telehealth. And I'm just going to stop sharing. I'll turn off my microphone, and Centricare team, it's up to you. And just let me know if you have any issues in sharing your screens. I think we're doing the purple crying first. Is it coming? Okay. So, Melissa, are you having problems uploading or sharing your video or your slides? Yes. Okay. Would you like me to pull mine up? Okay, I can do that. So we'll do purple crying first. So I will share the slides if that's okay.
Linda, I don't think that Melissa is a panelist. Melissa Bruns.
Okay.
She's not able to share or speak.
So she needs to be elevated to panelist. That's Carol. Thank you, Carrie. Okay. So that should work. So Melissa, let me know if you have problems sharing your screen. Sorry about
All right.
that glitch.
That's okay.
That's right.
Can you hear me now?
This is absolutely perfect. We can see your screen, and I will mute myself.
Can you hear me?
We can definitely hear you. Thank you.
Perfect. Thank you, Linda. Good morning, everyone. Thanks for having me. So I am just going to briefly share a little bit about our journey to implement a system-wide abusive head trauma prevention program here at Centricare. So within Centricare, we have 6 different delivering facilities. And we all know that there's been a statute on the books since at least 2005 that was updated most recently in 2019 that requires hospitals with obstetric units to provide educational materials to the parents of newborns. And so really this project began as nursing driven within St. Cloud Hospital and really within Centricare. This educational statute had always been met and documented by nursing. And around 5 or 6 years ago, a small group of nurse leaders at St. Cloud Hospital began exploring different ideas for updating their abusive head trauma prevention education for new parents. They had a program that they really liked, that really stood out to them, but at the time, they weren't able to implement it for a variety of different reasons. So in early 2019, we were able to revisit the issue of abusive head trauma prevention education for the families that we serve. So we started by identifying some of the goals that we wanted to accomplish with our abusive head trauma education.
We really wanted to inform families about the dangers of abusive head trauma in a way that would be clear, memorable, and meaningful, while ensuring, of course, that we're meeting the Minnesota state statute. Access was huge. We wanted to provide the education so that everyone had access to the same information and the same messaging. And so we wanted to use something that was available in multiple languages, ensuring that it's culturally competent so that the message doesn't get lost in translation. And we know that people learn best in different ways. Some people are visual learners, for example. And so we really wanted to be inclusive of different learning styles. We wanted to provide education that families can refer back to once they're home. We give them so much information in such a short time while they're in the hospital. So making sure that they could access the information outside of the hospital setting was important to us. And then looking at value and affordability. So we wanted to make sure that what we were providing families and what we were using was cost effective, but really, more importantly, added value to their overall patient experience. And so the problem started off really with just looking at what St. Cloud Hospital was doing, but ultimately evolved into more of an obstetric integration patient education project. So in the beginning, we started to try to identify what our current practice was across the system. And the first issue we ran into was that we had different movies and different patient education materials on abusive head trauma prevention being shown to families across our facilities. And so this really resulted in no standardized messaging to the greater community as a whole. The second issue is that Central Care has a very diverse service area. We encompass the more urban areas of St. Cloud and the surrounding metro, but also the more rural areas of central Minnesota. And so the population demographics within these areas vary greatly, and we need to meet the needs of everybody. And then the third big issue that we kind of identified was time, just the patient flow on the inpatient unit. Again, we have such a short amount of time with families, and often at the time that we do have with them, they're exhausted from the whole labor and delivery process. So we wanted to make sure that the messaging was clear and concise. That was very important to us. So there's lots of videos out there available on abusive head trauma. There's even a few pre-approved examples on the MDH website. And so when we were choosing a program that met our goals and fit our needs, we really thought about the needs of the families we serve. And we thought about those goals that I had spoke of earlier, and educating the families and the greater community on the dangers of abusive head trauma. We knew we wanted more than just another video to show. We wanted something that was inclusive and comprehensive. We wanted something that was evidence-based. We wanted to be sure it reinforced our safe sleep messaging and was also breastfeeding friendly. So we began to explore the different options for abusive head trauma prevention education, and we looked into the history of what the previous group at St. Cloud Hospital's findings and recommendations were. We did have a couple questions along the way, and the MDH staff was extremely helpful answering any questions that we had. We brought different program materials to our regional OB site leaders and providers and got their thoughts on it. We wanted to really, that was kind of at the point when we decided that, you know what, we really need to integrate this patient education on abusive head trauma so we could have really a standard and cohesive message to our communities. And so after discussions and weighing the different options available, really all of our sites were able to come to the same conclusion. We decided to go with the Period of Purple Crying. It was a program that fit all of our needs and really met all of our goals. A lot of you probably heard of the program. It's not new, it's been around since 2007. So I won't go into too many specific details about the program, but just over the next few slides, I'll give you a quick high-level overview of some of the basics. So really, the program approaches abusive head trauma by helping parents and caregivers understand some of the more frustrating features of crying that can occur in normal, healthy infants that can lead to shaking or abuse. And this is really important since we know that crying is shown to be the most important stimulus for shaking. So instead of just being limited to just warnings about negative consequences of shaking, this is really a positive program that gives parents and caregivers encouragement and tools that they can use to help calm and console their infant, and really focuses more on the crying and the impact that it can have on their family. It's based on over 30 years of research on normal infant crying. And if you're interested, you can check out don'tshake.org/purplecrying for some of the more recent literature on it. Purple is really an acronym, and I won't read them all to you here, but they're listed on the slide. And period just means that the crying has a beginning and an end. So this program is really meant to be delivered in 3 doses. The first dose is designed to be presented within the first couple weeks of life. And for us, this happens in the hospital. The second dose is reinforcement of the message. That usually would happen in a clinic or public health setting. And then the third dose is a public education campaign. So right now within Centracare, we have implemented the first dose and are in the process of implementing some of the second dose. So nurses who have completed the 1-hour training course provide face-to-face education with parents. They review the booklet and point out some of the highlights that are bulleted on this slide here for you. So every family gets a booklet with an app code or a booklet and a DVD, depending on what their preference is. And they can download the app to a personal device and view the Purple Crying video, or if they don't want to download it to their personal device, it can be downloaded onto a bedside tablet or shown on the DVD player in the room. And each family receives their own materials that go home with them. And so there's really 2 videos in the program. The first is all about the period of purple crying. And this is the one that we have families view before they go home. And the second video that they can view on their own or in the hospital if they choose to is really more about specific ways to soothe and calm their babies, and also involves some coping strategies for parents and caregivers. It really helps put some tools in their toolbox that they can refer back to once they're at home. And so our nurses really encourage parents to view the materials at home again and share the information with others who might care for their baby. One nice thing about the activation code for the web app is that it can be downloaded for up to 5 different devices. So it's not limited to just the main device that the parent uses. They can share it with grandparents, daycare providers, whomever they might choose. So our implementation, St. Cloud Hospital was our pilot for this program, and the group that began the rollout of the program was comprised mainly of nurse leaders on the birth center at St. Cloud. So even though on our inpatient units within Centracare, this has historically been nursing-driven patient education, we quickly realized that our providers were very interested in learning about this program as well. And some of our providers had even used this program in previous positions outside of Centracare. So we brought them all on board too. That was really great. We planned the implementation of the pilot of St. Cloud Hospital in the summer and fall of 2019. And as we rolled out the pilot at St. Cloud, we started meeting with some of our regional site leaders and OB leaders to share what we had learned from the St. Cloud Hospital rollout and to really try to identify any issues that might be specific to each site that we hadn't encountered yet, and really just to make sure that the program rollout would be successful for each site. And so with the successful rollout of the period purple crying education in December of 2019 at St. Cloud Hospital, we began more formal planning for the project rollout with the regional sites for early 2020. So we started bringing it to all of the nurse meetings and obstetric department meetings, and really just keeping the conversation around this going. We met with site educators along with nursing leaders and providers from our regional sites to kind of plan the education of the staff and roll out the program, and really to identify any barriers to the implementation that could really be site specific. So we had the implementation plans set for early 2020, and then of course our friend COVID hit us. And so in the early days of the pandemic, there were a lot of uncertainties, and so we ended up putting our implementation temporarily on hold. But once our teams were able to catch their breath a little bit, the educators for each site met, and we planned a fast rollout of the nursing education and the revised go-live date for our regional sites. And we had amazing support of our OB and our site leadership. And so we, again, wanted to make sure that we had a fast rollout of the implementation because we didn't know what tomorrow was going to bring. So we knew we had time right now. We really just wanted to get it out there and get it rolling. So we were able to go live in September, and ultimately COVID delayed us about 3 months. But the rollout has so far been a success, and we learned some lessons along the way. And number one was patience. So throughout this process, it really became evident that each site is unique not only in their name, but there are also some cultural differences. And so even though we're close geographically speaking, there are differences from site to site that we needed to acknowledge and honor. So some variations in practice and workflow can sometimes make for challenges. So the second big lesson learned was it was really important to involve stakeholders from each site to help the larger group fully understand the impact of the proposed changes that it will have on each site. The third big lesson that we took away from this was communication. It was so helpful early on to clarify whose responsibility it was to communicate with their site, to keep that conversation about this project going. So in this case, our regional educators and the site OB coordinators were amazing. Not everyone in the group was able to make every single meeting or every single phone call, but you throw in COVID into that and wow, we had our hands full. So throughout the entire process, we had really open lines of communication. We touched base frequently, and this was very helpful as we tried to monitor the situation at each site and really gauge when the best time to move forward with the project would be. And so this also was very helpful as we planned for that quick implementation that required the staff education to be completed first. And the fourth takeaway was flexibility. So even the best laid plans, right? And I think 2020 has given us all a crash course on the importance of being flexible and being able to adjust and adapt our plan, sometimes multiple times, was really crucial to the success. So our next steps would be implementation of the second dose within our clinics. We've completed our nurse education for our largest pediatric clinic with the intention of rolling out that second dose with the new year. And we've started some of the planning for the second dose in some of the regional family practice clinics with the hope to continue to spread it to the rest of our clinics and continue to reinforce the education. So thanks for letting me share our journey with you today. Linda, I'll toss it back to you.
Okay. Thank you so much. This is wonderful. It's just great to see what you are doing there. I'm going to invite Melissa and Diane just to share their slides and do their presentation. And for the attendees, feel free to put your questions for the whole Central Care team into the Q&A. We'll have probably we're running a little bit, behind schedule, but it's not terrible. So we'll have a short question and answer for the whole Central Care team, and then we'll move along to Bobby Phillips after this. Thank you so much. Feel free to go. And if you are speaking, Melissa and Diane, we don't hear you.
Can you hear me now?
Now we can hear you. Okay, there you go. Okay, I'll mute myself and you'll take it away.
Okay. So this is Melissa Lane, Director of Family Birthing, as you had said before, along with
Diane Pellin, Director of NICU, and we are thrilled to be able to share with you our innovative special care nursery program.
There they are.
Okay, so to start with, right care, right place, right cost. This was really important to us to assure that we are giving the best possible care to the infants that we take care of and also to the parents that we serve. Just to, okay.
You have to fail. Sorry, we're doing this tag team. It's a little bit.
So just very briefly, we wanted to share with you just Central Care at a glance. For those of you that don't know, we are a 489-bed regional medical center and the only tertiary hospital in the primary service area. And we always like to share a picture of our beautiful setting, and especially now with that we are on obviously the Mississippi River, and with the weather as it has been of late over the last week, it's been absolutely gorgeous outside. A quick overview of what our postpartum rooms look like, as well as what our NICU room looks like. And as you can see, there is definitely a space, as within most facilities nowadays, a place for the families to basically move in if they so choose, especially into the NICU space.
This is just a depiction of our Central Care's professional practice model. for our RNs. And we felt like the virtual special care nursery, which we're going to tell you more about here shortly, fits very well into the four spaces here. So obviously with nursing care delivery, we had our NICU RNs train our birth center RNs regarding this sort of step down from NICU care with that exemplary professional practice, following late preterm infant guidelines, which led to much professional growth for the birth center RNs, and certainly a skill set that most, if not all of them, have really enjoyed learning. And then we moved down to South, or shared governance. It did take a big multidisciplinary team to develop order sets, policies, procedures, criteria for admission and discharge, all of those things. So that's the shared governance piece. And then we move over to working relationships, which have only gotten better and flourished between not only birth center staff with the NICU staff, but with pediatric and NICU providers as well. And then the quadruple aim, which is part of CentraCare's strategic plan, including all of these things, also fit well with our virtual special care nursery. Improving the health of the community, and we'll get into a little bit more detail of that. Enhancing the patient experience specifically to the families, the moms on the birth center. Reducing the cost of care, and you'll hear more about that. And improve provider and staff well-being and satisfaction.
So why did we even take a look at having a virtual special care nursery? Special care nurseries are not new for any facility that has a postpartum unit and a NICU. We had an opportunity to look at where and how we could adequately take care of those infants that somehow kind of fit right in the middle, not necessarily a candidate for being in the newborn nursery, but really not sick enough to be in the intensive care unit. So we were looking at ways in which we could use our space effectively, how we can effectively use our resources, and then again, as Melissa had mentioned previously, improve our family and staff provider satisfaction. So just a quick question, and obviously you could say in the chat how many people know what this is? And I'll just see if there's any, we'll see if there's any comments back in the chat group. Okay, if not, this is in CentraCare, we have been on a journey of a culture experience, and that is called Our Best Begins With Me. And one of the things that we have been focusing on is the principle of staying curious. And so what this is a wheelbarrow. Now, to most of us that know what a wheelbarrow looks like, this isn't the typical wheelbarrow. And it's a good reminder for us all to look for when we move forward with new ideas, new processes, procedures, etc., that we need to take a step back and look at things from a different perspective, needing to be, and again, remaining curious.
So now you might ask, well, what did we do to achieve this successful implementation of the virtual special care nursery? We had many brainstorming sessions with all of the stakeholders that we included. And we had this goal for many, many years. We talked about it honestly for probably 15 years on how we could keep these babies with higher level care needs in the bedrooms, in the patient rooms with their moms. And we needed to understand where we had been and where we wanted to go. So we did bring that group of stakeholders together. We talked about that. We completed a SWOT analysis to better understand what we were doing well and what we needed to improve on. We also completed a financial analysis, of course, to compare our current model and what it would look like if we moved care to the birth center versus using precious NICU beds. And then we also developed education, of course, for birth center staff and providers, pediatric providers, using that late preterm guideline toolkit as our Bible. The how did we do this? Of course, these infants do require closer observation by nurses who are specially trained to include things like gavage feeding, high-intensity phototherapy, IVs for glucose control and our antibiotics, and of course, temp stabilization. So we do not do anything, of course, on the birth center related to any cardiac monitoring, but all those other things that I just mentioned. So historically, infants needing this intermediate care would be transferred to the NICU, thus unnecessarily separating moms and babies or babies from their families, which also leads to increased cost of care that's not necessary. And then, like I said before, taking that valuable space out of the NICU for babies who really need it. So again, we did some additional training for the birth center RNs on the unique aspects in caring for late preterm infants, as that's where we started. We had a mandatory stable course that these nurses had to complete, along with simulations and skills. And like I mentioned before, we developed admission and discharge criteria, order sets, and policies, all as a stakeholder group.
Right, and just to tag on to that, one of the principles that we kept at the center of everything that we were doing was the patients and their families, and I think, or the infants in this case. And I think with that focus and really looking at the wheelbarrow in such a way that, so we didn't want to do things just to do them. We wanted it to make sense. We wanted it to be patient and family centered. And of course, we wanted the infants to receive the best possible care that they could.
So measures of success. We did have our grand opening January 2nd of 2017. So we're going strong. We did have successful implementation of providing couplet care at the bedside on the birth center. We have had increased parent, of course, families, staff, and provider satisfaction in the way that we have this set up. Leaders on the birth center, including myself, do leadership rounds on patients and families before they leave. And I've heard several anecdotal comments from families about how grateful they are to be able to keep their baby at their bedside and avoid the NICU separation. And those who have had it both ways, of course, are just very thankful that we've implemented this program. It improves bonding, of course, feeding outcomes. It gives parents opportunities to learn the cares for these unique infants right there together. We've noticed a decreased length of stay, and of course, a decreased overall cost of care using, not using those NICU beds at that expense. And so you can see on the screen here that we had data from when we implemented on January 2nd of 17 until the end of June of this year, and we affected 650 babies and their families in a positive way by keeping them all together with an approximate savings of about $750,000 on the budget. So about 6.8% of babies in Minnesota are considered late preterm, which includes babies born between 34 and 37 weeks. And we'd like to just share a story of the first special care nursery infant who benefited from this care. And so we worked with the St. Cloud Times to put together this story and interview this family. So
what I am going to do is I'm going to stop sharing my screen, and Melissa is going to share her screen so we can get the video up and running quicker.
You know what, I wonder if I'll be able to, because this isn't within the Zoom. You know what I'm saying? Sorry, you guys, we're trying to figure out if I can even do it. You might have to do it, Dan, but I can. Hang on 1 second. It's only 1 minute video, and it's worth the wait. So yeah, just go ahead and. Oh no, come on.
This is Linda. I think I have the link. So if you want to stop sharing, I can, or even minimize, I may be able to share from my slide deck.
Do you see it coming up?
No.
You don't? Oh, we're still on. Here, wait, do you see the St. Cloud Times ad?
No.
Oh.
Okay, why don't
you click on New Share? Can you click on New Share?
I'll just hit Stop Share.
Okay,
And
let
then
me
you-
see if I can do it from my slide deck.
Okay.
Thank you.
Sure.
Sorry.
You're fine. Okay. Or what we might be able to do is we could also send it out on Monday with all of the, I'm sending out the other, like the testimonial videos. Would we be able to send this out on Monday?
Are you able, do you see it now?
No.
I see
Oh,
something.
now, yes, I
ST
do.
time.
Now I see it. Okay, go ahead. Yes, we do. Hooray.
Okay, perfect. Okay, still?
Looks good.
Okay. Oh, you guys might not.
So if you pause and when you share, you need to.
There we go. It's
good.
It's coming. Okay. So, can you hear me still okay? Now.
Yes, we can. Yes,
Okay.
thank you. And feel free to share your video.
Here with St. Cloud.
I'm not
Sorry,
sure if you have.
For the
I have a couple of questions, one for each group.
Yeah,
absolutely.
Awesome.
Okay, it'll just be a couple of questions and then we'll pass it over to Bobby. And this is actually a perfect segue to what she's going to be speaking to. So the first question about purple crying was, how does this, at the very least, not get in the way of breastfeeding and breastfeeding education? And at the most, does it facilitate and support breastfeeding?
I'm sorry, I missed that first part of that question, Linda.
Just the relationship between purple crying and the breastfeeding education and support. At the very least, how does it not get in the way of breastfeeding? And at the most, how does it support and complement breastfeeding?
Well, I think educating parents on the whys behind the infant crying and that this is normal, and in the literature, in the videos that they show, they never show bottles, they never show pacifiers. They instead emphasize different ways of calming and consoling and keeping that baby close by the caregiver. And so I think in those ways it really enhances our breastfeeding education that we provide about keeping that baby close to mom and the skin to skin and all of those things. Fabulous. And the second question we have that's for the special care nursery folks. So what about the period of discharge? Is mom often discharged before baby, or how does that sync up?
Yeah, that's a good question. Can you hear me okay?
Yes.
Okay. That is something that we worked really hard on too, to really treat them as two separate patients. And so really focusing on discharge when medically ready, whether it's mom or baby. So if mom is or if baby's discharged first, or either way actually, if let's go mom is discharged first and baby still needs a couple of nights of whatever, we allow them, we just keep them in their room. The mom can stay as a non-patient, and we give them a little gift card for food once per day, just to help them out with that a little bit. But no, she can stay in her room in the comfort of where she's been, and we just keep giving that baby the care we're giving him.
Right, and this is Diane. I'll just tag on to that. I think the beauty of this program and how we have it laid out is the virtual piece of it, meaning that across our third floor, whether it's on pediatrics, NICU, or in the birthing center, wherever so in the situation that Melissa just stated, the mom is discharged. For example, if the birth center is full with obviously new moms and postpartum moms that are actively delivering or have delivered, we then can move both mom and baby down to our pediatric unit, and they can stay together again, not having to separate them, but the baby is still receiving the care that he or she needs. And the NICU is the same way. If for whatever reason peds happens to be full and NICU has a space, then we take both mom and baby in there. So it's not necessarily, again, about the actual space or location. It's about just keeping that couplet together and bringing the care to the patient.
Thank you so much. We, the broader Minnesota Breastfeeding Coalition community, we're so grateful to CentraCare for sharing not only your really excellent practices and your innovations, but also your amazing people with the rest of Minnesota. Thank you so much.
Thanks for giving us the opportunity.
Yes, our pleasure.
Thanks for
So I'm going to
having us.
pass this directly to Dr. Phillips again. She's going to close us out today, and I know we're running a little late, but so we may go over time, 5 or 10 minutes. This is not a rush job. We'll expand our time to fit the conversation that needs to be had. So Dr. Phillips, I'm going to mute myself. I'm going to let you share your video or your screen. That's perfect. Just need to do the slideshow view.
Yep.
Excellent. You have mastered this. Excellent.
Awesome. All right. Can you hear me now?
We can hear you perfectly. Thank you.
All right. So hi, everyone. This is kind of a perfect segue, I think. So I just want to do a shout out to Linda, who's just a master of ceremonies extraordinaire here. So thank you for your patience for the—
You're welcome. Thank you.
Thank you very much. All right. So yeah, I think we might end pretty much on time, which will be good for everyone. So I'm going to talk about early bloomers, best practice care for late preterm infants. I have no actual or potential conflicts of interest to disclose. So here we are again. You've already seen this back at Boston Medical Center. Interesting, the statistics that that was just revealed, it was fairly similar. So at Boston Medical Center, we have 8 to 15 births per month who would be late preterm. So that's about 5% of our births per year. And as you know, we've been baby friendly designated for 20 years, and our routine is rooming in, immediate postpartum skin to skin care, and delayed bath. So by definition, you've heard this before, but late preterm is defined as 34.0 to 36.6 weeks gestational age at birth. And every hospital has their own way of managing late preterm infants. So I will just share with you what we do at our hospital. So any infant at our hospital who is born less than 35 weeks is admitted to and stays in the NICU until discharge. And our NICU it's a family-centered care unit, so families can stay in the room with their baby, which is great. Infants who are born 30.0 to 35.6 weeks, they are admitted to the NICU for 12 to 24 hours of observation, and then they transfer to the mother-baby unit. We're all on the same floor, just down the hall, if they are stable. So they're watched a little bit just to make sure they're not having breathing spells or apneic spells. And then any infant who is born 36 weeks or greater, in this case 36.0 to 36.6, are admitted directly to the mother-baby unit. That's how we do it at our hospital. So as we've heard, these are vulnerable, high-risk babies. Problems that they can have that can lead to mother-baby separation. They can have respiratory distress and have to go to the NICU. They can have hypoglycemia and need to get gel or donor milk or formula. They can get cold and have to go into an incubator or on the warmer. If they need an incubator, they go to our NICU. Their billy levels can be too high, need phototherapy. They can have a prolonged length of stay being in the NICU, and the mother is discharged, causing separation. And because they're more immature, it can cause breastfeeding difficulties. They can be hypotonic. They can have poor head control. They can be easily fatigued. They can have difficulty with their suck and swallow. I always tell the residents I work with that late preterm infants are the great pretenders, that the baby born at 36 weeks can really be a 36-weeker developmental wise, or it can be a 34-weeker or a 37-weeker, but they're always pretty pokey eaters is what I share with them. So when our unit looked to address what we were doing for late preterm infants, we really all recognized that we needed to do better, because remember, we could have some 36-weekers admitted directly to our unit. And we felt that they were kind of being clumped in with all the bigger babies. Nothing special was being done for them. And we know that this is a very important window of time for these babies, because a baby's brain at 35 weeks weighs only 2/3 of what it will weigh at 39 and 40 weeks. So these are very vulnerable babies, and there's an opportunity window there to really help them out. So how to make this change happen in a hospital setting? Change is hard. We've talked about this. So Ginny Combs, who I've mentioned, who is our nurse manager, is an innovator of change. And she was behind a lot of this, so I want to give credit to her. She shared her thinking about how to make change happen on a unit where I think that she has 65 or 70 nurses that she's in charge of. So you can see that the diffusion of innovations. You can see that this chart shows that on your unit, you could have, in terms of people who are going to be willing to adopt change, you can have people, you're going to have innovators, 2.5%, all in, way ahead of the curve. You're going to have early adopters, 13.5%, interested. The early majority, 34%, they're pretty interested. The late majority, 34% coming along, and then you have the laggards at 16%. So if we look at these different groups, and I really like this curve because I think it is spot on, and I could take physicians and nurses and kind of plug them in here. So the innovators, all in, they're the risk takers. The early adopters, they're good. They want to have a go at. They're willing to try. The early majority, kind of watching what's going on, wondering what's going on over there, might be a little bit interested, haven't shut everything down. The late majority, they're kind of the ones that are like, oh, well, I guess I'll do it. Everyone else is doing it. And the laggards are simply the ones that are just not going to change, no matter what happens, and they just want you to leave them alone. So strategies when you're looking at this method, number one, try to keep the laggards out of the space of the innovators and early adopters. Spend your energy on the innovators and the early adopters. Get them to move to where you want to go. And the thinking is they're going to pull everybody with them except the laggards, who you're not going to worry about. Remember that we won't move people out of their category, but we will tailor our work for each of them. So for an innovation to stick, for an idea to stick, there we go. For an innovation to stick, it needs to be perceived as better than what you were doing before. It needs to be compatible with what you believe. It needs to be easy to understand. Keep it simple. You got to make it early to trial. It needs to be easy for others to observe beneficial outcomes and people talking about it on the unit like, man, this is really great. And it needs to be easy to adopt and change. The message coming from leadership needs to be clear, succinct, simple. Why am I not advancing here? All right. So when we sat down as a unit to think about this, the first thing that we did as the task force and with the unit was to think big. What were in our dreams? What would we love to have happen? So we wanted to support thermoregulation and glucose levels. We wanted to identify as high risk these late preterm infants. We wanted to address their feeding challenges and offer optimal support. We wanted to plan for staff education. want to make sure you can see me here. Yep. And we wanted to offer optimal support with our discharge planning. So those were our big dreams. So the journey began. A multidisciplinary task force was formed. It consisted of NICU nurses, mother-baby unit nurses. There was a nurse practitioner from the pediatric team. Some of the IBCLCs were involved. The mother-baby unit and the NICU nurse managers were on the task force, and the newborn and NICU educators were on the task force. We have 2 of those. The task force ordered the AWAN, late preterm infant brochure, to have a look at. And the task force held a contest to name the late preterm program at Boston Medical Center. And the winner, so nurses thought about it, talked about it, doctors thought about it, talked about it, put in ideas for the name. And the name that won was Early Bloomers. And this is kind of a pic, and I love the kind of the logo, the Early Bloomer logo with the pink and the blue flower there. So this was slow going at first. There were weekly early bloomer meetings with the task force for over a year. And they thought about things, they thought about logos. The task force worked with marketing, and there were many edits for the swag gifts that we were going to have and order processing. And they developed and tested these swag bags. It took a while. Things were slow moving in the beginning for the task force. The unit didn't really know anything was going on except this early bloomer program, which they were kind of hearing about, but the task force was hard at work. So the early bloomer program, you know, it's all about the swag. When the mother arrives on the unit, let's say she gives birth to a 36.2 week infant, and the mother is stable and the baby is stable. When the mother arrives on the unit, she receives a welcome bag. And this is kind of what it looks like, the contents of the bag. We're going to go through all of them. Right now, it's just kind of a Ziploc bag. It's not a real fancy bag, but it's what's inside that's really important. So first of all, they receive a special hat, and it's really cool on the unit because once you know, we have just the plain colored cotton hats for babies. And then when you see a baby who has this hat on, you know that they're an early bloomer. There is this card that I showed you before, and that is hung from the baby's bassinet. It helps us identify the early bloomer and also gives some reminders to everybody on the unit, including the family. So this says, I'm an early bloomer. Help keep me warm, feed me often, hold me skin to skin, and love me lots. And you can see at the bottom is the Boston Medical Center logo with early bloomers. And again, the marketing department helped a lot with this program. In the welcome bag, they also receive this little Ziploc bag, and this has the colostrum spoon, the blue spoon that you can see here. You guys are probably familiar with that. And when the mom fills the spoon up, that's 1 ml. And then there is one of those QRC codes that the mother or father can wand with their phone, and that leads you to a hand expression video easily. Then there's bedside table information, which is this. So what it does is they just kind of fold it and then they put it on their bedside stand, and you can see it says early, this is the front of it, Early Bloomers Parent Guide. And then this is the back of it. My name is, and the nurse or parents fill it out, and it says, help keep me warm by keeping my head on at all times while in the hospital, holding me skin to skin on your chest as often as possible. When I'm not being held skin to skin, please dress me and swaddle me in light blankets. My nurse will be checking my temperature under my arm every 4 hours, and my temperature should be, as you see. My feeding plan. Feed me on demand, but at least every 2 to 3 hours. Sometimes I need help waking up to feed. I need to eat at least 8 or 12 times in 24 hours. My mom can pump and or hand express after I eat. I may need to be given extra milk after I breastfeed. Ask our nurse to watch me feed to see if I need more. My mother prefers to feed me. My special requests are, and that's who completed it. A lot of good information there. I want to say that at the task force, coming up with the wording for that bedside guide took a long time, making sure we had the right wording. Then we came up, we developed an early bloomer policy. And as you know, policies take a while to write. And that took about we came up with the policy, it was passed around, 6 months of revisions. And then we have an early bloomer order set for EPIC. So when the baby is admitted, the pediatric team uses this order set. And these are things that the order set has in it. So number one is they get vital signs every 4 hours for the length of their admission. On our unit, term babies get vital signs every 4 hours for the first 24 hours, and then it shifts to every 8 hours. It has an order for hand expression and a spoon feed after breastfeeding attempts. It has on the order set add-in pumping at 6 hours as needed. These babies get an immediate lactation consult on our unit because our nurses are so rock star great about breastfeeding knowledge and teaching. Remember, there's some nurses on our unit that have also been there 20 years and have gotten all this teaching and all these competencies, like a lot. So not every baby on our unit gets a lactation consult, only if it's needed, but these babies get an immediate consult. The donor milk consent order is in there. As I mentioned before, the bath is delayed for 24 hours or longer, and they have to be feeding well before they get a bath. And they have to be feeding well before they get a circumcision, delayed for at least 24 hours. The order encourages safe skin-to-skin holding. And we instituted feeding huddles as necessary, starting at 12 hours of life. So if the baby wasn't feeding well or the weight loss was getting to be too much, you would hold a huddle with the nurse, the physician, the lactation consultant, and the parents to talk about what was going on and come up with a feeding plan. So the next big task was to educate staff, nursing staff, about the early bloomer program. And this was layered over 2 years using different modalities. This was included in one of their competency day trainings. Small group huddles were held to talk about the early bloomer program and answer any questions. Articles were sent out for the unit to read. The lactation consultant, the educators, and the nurse did in-services. And then we used PDSAs, Plan, Do, Study, Acts, to identify gaps. And one thing we found out was that the CNA really wanted to be involved. So we worked on that. We learned some things and fiddled with the order set. And one of the things that we added was the feeding huddles starting at 12 hours. So you learn things when you do PDSAs. You trial one nurse, one baby, one doctor, one family, and you trial things and you see how it works. So opening day was a year ago, April 1st, 2 years ago. This was before COVID. The program was set to start on April 1st because we could tie that up with springtime. Ginny's idea, who was really the brainstorm behind this, was to make it fun and create a buzz on that first day. So she made all of these hats for everyone to wear on the first day on the unit, and we had t-shirts made, and there were snacks, and she posted a lot of pictures and a lot of comments on the BMC Mother Baby Unit Nursing Facebook page. So is it better if we look at that innovation curve? Remember, was the early bloomer program better than what we already had? Well, absolutely, because before we started this, we had nothing. And the late preterm infants were being lost in the shuffle. So we could put a check in the yes column for that one. Is the early bloomer program compatible with our beliefs on the unit? Yes, absolutely. And the big sell for the nursing staff, what they reported back, was seeing the brain image and learning that stat about brain growth was really important. And they realized we had to take special care of these babies. So we get a check in the yes column. Was it easy to understand and easy to implement? Absolutely. The policy was clear. The crib card was great. The order set was great. It was easy to understand. Was it easy to trial? Yep. We did PDSAs, one baby, one nurse, then adapt from what we learned. Could we see benefits from the program? What happened was the nurses who were the early adopters, who are the ones that were asked to do the PDSAs, would share in the morning huddle, and they would talk about it positively, and they would talk about what they liked about it. And is the Easy Bloomer program easy to customize? Yes, it is, and we are continuing adjusting and changing. So the feedback from the nurses was very positive. They reported that it increased their hand expression knowledge and skills. They reported that the swag and the information helped them identify high-risk babies and think of them a little bit differently. They thought that the swag bag was excellent and helped with education. And they really appreciated that the early bloomers were identified on the assignment sheets, and there was consideration of the acuity of these dyads for assigning patient to nurse ratios. Our unit, Ginny tells me that we have, in general, during days, we have one nurse for 3 dyads. There are fewer dyads if the mother's on MAG, I know that, and they adjust if they think that that these late preterm infants are going to need a lot of care, a lot of time. That's feedback from parents. Feedback from nurses. Feedback from parents. The parents reported that the hat, they thought that it was awesome. They didn't really understand why the nurses were wearing those hats with flowers, and some parents reported that they thought that this was how Boston Medical Center celebrated springtime, which is cute. The parents appreciated reminders of the special needs of their babies. The parents thought that the swag was cute, and the parents love the hand expression video and the spoon. And we've done some tweaking. Remember, this was 2 years ago, and over the 2 years, we've done some tweaking, like I've shared with you already. We now are using Swaddle immersion baths, and it's so very, very important for these babies that are at risk to not be stressed early on. So we delay the bath, and when the bath is done, if it's done at all, I don't really care if the babies get bathed. If the parents want it, it's fine. But it's done with the Swaddle bath with the turtle tubs. And then, as I told you guys recently, now the nurses and the lactation consultants can get the donor milk consent, which is totally awesome. So everyone on the unit is really pulling together. So we have some future plans, for the early bloomers. Once again, you get a program in place, you got to keep working on it. So we're going to polish it all and keep sustaining it. There's an idea, I think when COVID calms down, that there will be a phase 2 for the NICU. Because remember, we've got some 35-weekers in there, and we've got some babies that are going there for a little bit and then coming out to us. We want to move labor and delivery to get everyone doing hand expression down there. We really need swag bags in different languages, and the marketing department's helping with that. And we have some studies ongoing by one of our family medicine docs, Kate Standish. And she's diving in and looking at data for 2 years before early bloomers was started, and then 1 to 2 years after it was started. And we're looking at what happened to breastfeeding rates, what happened to phototherapy, what happened to use of donor milk, what happened with hand expression, and readmission data. And she also wants to do some qualitative studies to assess parent and nurse feedback. So isn't this nice? I finished with plenty of time for questions. And Linda, I think we're going to finish on time.
It's absolutely perfect. Thank you. I see one question so far, but I just have a couple comments, one from the chat and one from myself. So the first one was in the chat was how wonderful it is to have this with a sort of a positive spin. It's through a positive lens rather than the usual negative lens that we look at these, late preterm babies, like how challenging they are, but it's a positive spin. Another comment is from myself, when we were sitting, my colleague and I, when we were working on the evaluation and going through this slide deck, and we saw the QRC code with the spoon, through Zoom, with our phones, your slides through Zoom, we could access that video. And it is the Stanford
it's the Jane Morton
expression video.
Oh, that's awesome.
But we're like, we want to see if this works. And it worked for us, even through Zoom and whatever. So it was wonderful.
So when the attendees get the slide deck, they can do the same thing.
Yes, absolutely. Absolutely. So a couple of questions have come up in the Q&A. One is, do you create your own hand expression video? Oh, well, that was just the response. So the QRC code actually links to the Stanford University hand expression video. And there are others. There's the Global Health Media hand expression video. And yeah.
I think with YouTube, I always tell dads, hey, can you pull up your phone on YouTube, type in pace bottle feeding.
Yes.
And then you watch that. Yeah.
And somebody asked, what else comes in the swag bags?
The swag bag has the QRC code with the spoon. It has the hat. It has the thing that hangs on the bassinet, and then it has the bedside little education thing that becomes a tent on the bedside. It's that picture that I showed of those things laying there.
Yes.
That's in the swag bag.
And the last question I see is, how do you get docs involved in the feeding huddle?
It's easy.
Really?
Well, it probably depends how your docs work, but our pediatricians are there all day. I mean, when I'm attending, or our pediatricians are attending, we're on the unit for 12 hours, and we always have a pediatric resident that's working under us. So we're there we're just there. It would be harder, right, if the doctor is not a hospitalist and they're coming in from their office. That would be harder. The doc doesn't have to be at the huddle. It's just we really try to communicate as teams across modalities. So, yeah, it's just the way our system's set up. It's easy. Excellent.
This is perfect timing. We are ending on time. We've had all of the presentations, and thank you so much. I'm going to stop sharing this and go back to our slide deck, and a huge thank you to our two keynote presenters, Dr. Kim and Dr. Phillip. I really appreciate you sharing your wisdom, experience, and insight from afar. Thanks to the Minnesota Breastfeeding Coalition membership and leadership, the summit planners. We had an amazing planning team. All of our hospitals in Minnesota, leadership and staff, and all of the chest and breastfeeding families everywhere, because we exist for you. And I just want to remind you, I'll be sending out on Monday, I'll be sending out the links to the recorded summits. So the 2 parts of the summit, I'll send out those recordings, the link to the evaluation, which will tie to your certificate of attendance and CEUs. The video testimonies, which will have subtitles. The 2 things that Dr. Phillip sent, which is the article and then the information about Bella. And anything else that we accumulated today that I need to send out, I will do that on Monday. I'd like to pass this over quickly to my fabulous co-chair, Pam Heggie, to close us out. And I think she's still here.
I was talking, but I was
muted. You're muted. Okay.
So I was saying thank you so much to you for your IT skills and your facilitation and just, yeah, your way of bringing us all together and being creative. And I really appreciate that. And also, I'm just so proud to be in Minnesota and to hear about all of the innovations and the passion that we all have for moms and babies and families and parents and breastfeeding. And I'm just really inspired, and I continue to be every time we do these summits. So thank you, everyone, and be safe and be well, and keep up your cheering and support of one another, and be kind. Thanks.
Thank you.
Thanks, everybody. Bye.